video based. Okay, so I just want to tell everybody that in the beginning, about 2 to 3 minutes, is basically we are talking about the person that who is a common person which is known to me, and incidentally, she was a close friend of my neighbor. So I didn't want to skip that part because I want to show you like we have to build a doctor-patient relationship while doing the examination, so that and to record video also I had to take her permission. I have to make her happy so that she will be ready to take the video. Okay, so I'm really sorry for the initial 2 to 3 minutes of conversation regarding our neighbor. Okay, with that I'm starting the video. हजुरको नाम अनिता श्रेष्ठ, हजुरको उमेर 60 वर्ष। सो घर ललितपुर, के समस्या लिएर आउनुभएको? इखालुको है, मेरो घर त नजिक हो नि, मेरो त क्वालपुर नपसल भनेको बङ्गलामुखी जाने नजिकै चाहिँ मेरो भयो। तपाईँको चाहिँ इखालुको भने मापालबाट नपसल भनेपछि त्यो नपसलेमा त हाम्रो विश्वबा भन्ने चिन्नुहुन्छ, बित्नु भयो नि, उहाँ चिनिहाल्छु नि, त्यो मेरो साइला। ए विश्वबाको एकदम मिल्ने साथी मोहन प्रसाद र माथि चाहिँ मेरो ठुलो बुवा, उनीहरू जहिले पनि पसलमा रङ पसलमा बसिरहन्थ्यो। चाहिने सासूको श्रीमान। ए ल, विश्वबा त अस्ति कोभिडमा बित्नु भयो। त्यहाँबाट सोध्या अगाडि म चाहिँ गोविन्द राज श्रेष्ठ, गोविन्द राज श्रेष्ठ भनेको ए मेरो घर चाहिँ विश्वबाको घर देख्नुभयो तपाईँले। र त्यसको सबभन्दा छेउमा एउटा भत्किन लागेको घर छ नि, त्यो चाहिँ मेरो म जन्मेको घर चाहिँ त्यो भयो नपसलमा। तर त्योभन्दा अलिक अगाडि गयो भने चाहिँ राजभण्डारी चोकमा चाहिँ म बस्ने चाहिँ त्यहाँ हो। र विश्वबा र मेरो ठुलबा चाहिँ एकदमै मिल्ने। मोहन त्यो तपाईँले सुन्नु माजु माजु भन्छ, माजु माजु भन्छ, उहाँ चाहिँ मेरो ठुलो बुवा। विश्वमा अस्ति छोरा पनि बित्नु भयो त्यही यहीको यसमा, त्यही बेलामा सँगसँगै छोरा र उहाँ दुईजना अर्को बुढा अनि उहाँको छोरा हो। त्यो त छोरालाई फेरि किडनीको पनि समस्या थियो अरे, त्यो भएर पनि चाँडै बित्यो। जात्रा भइहाल्यो। तपाईँले चाहिँ समस्या अहिले घाँटी पछाडिको घाँटी यो दुख्यो, जस्तो तपाईँलाई के समस्या छ? मेरो घाँटी दुख्यो, अनि त्यो दुखेपछि यो पछाडिबाट खोचिहाल्छ हुन्छ, पछाडि घाँटी हजुर, अनि यो हात त्यो मसल पुरा दुख्छ। कहाँसम्म दुखाइ आउँछ यो? यो मसल त यहाँबाट यहाँसम्म, यो औँलासम्मै आउँछ। यहीँसम्म कुन औँलामा धेरै आउँछ? बुढी औँलामा धेरै आउँछ कि यो तिनवटा औँलामा धेरै आउँछ कि यहाँ धेरै आउँछ? यसमा पनि आउँछ। सो यो खुम्चाउन नै डर छ। र यो दुखाइ कस्तो छ? झमझमाको पोलेको जस्तो छ कि भित्रबाट कट कट खा जस्तो छ कि लाटो पनि हुन्छ कि कस्तो छ? पोल्न नि पोल्छ, बर्निङ छ, भित्रबाट कट कट खान्छ, यो मसलै के भएको जस्तो। र यस्तै दुखाइ यहाँ पनि त्यस्तै हो, जुन चाहिँ तपाईँले झमझमाउने कट कट खान्छ लाटो हुन्छ भन्नुभयो। यो पछाडिको मसल यो पनि दुख्छ। र यो दुखाइ र घाँटीको यो पछाडिको दुखाइ यो उस्तै हो कि फरक छ? यो दुखाइ र यो दुखाइ उस्तै छ कि फरक? भन्दा चाहिँ यहाँ बढी दुखिरहेको छ अहिले चाहिँ घाँटीमा भन्दा मसल। यो समस्या भएको तपाईँलाई कति भयो? 2 महिना? 2 महिना। तपाईँलाई के गर्यो भने यो समस्या बढ्छ र के गर्यो भने यो समस्या घट्छ? यो 2 महिनाको अन्तराल केही नगरी चुप बस्यो भने अलि कम भएको जस्तो, पानी सानो चलायो, भाँडा सानो चल्यो भने रेस्ट गर्यो भने कम हुन्छ, तर काम गर्यो भने चाहिँ दुख्छ। र राति पनि दुख्छ? राति कस्तो छ? राति पनि दुख्छ। कहिले बेला त यो यता तकिया यता यता थिच्दाखेरि यो खुब पनि दुख्छ। सो तपाईँलाई तपाईँलाई के यो हात यसो माथि गर्यो भने अलि आराम हुन्छ? सुत्न त म यसो गरेर सुत्छु, अलि आराम हुन्छ, अलि आराम गर्छु, अलि आराम हुन्छ। र तपाईँ खोक्नु भयो, कट्नु भयो नि यो दुखाइ बढ्छ? जस्तै खोकी लाग्यो तपाईँ खोक्यो भने यहाँ तल सबै दुख्छ, तन्केको जस्तो हुन्छ, कफले पनि बढ्छ। र आँची गर्दाखेरि कस्दाखेरि पनि यो हात दुख्छ? बढ्ने त छैन, यस्तो बिसाउँदाखेरि तर खोक्दाखेरि त दुखेको अनुभव हुन्छ। आँच्यु गर्दाखेरि आँच्यु गर्छौँ नि हामी कहिले, त्यो गर्दाखेरि पनि बढ्छ? आँच्युलाई त्यति आएको छैन, खोक्दाखेरि चाहिँ यो ठाउँमा पनि आएकै हाल्छ। करेन्ट लाग्छ, इलेक्ट्रिक करेन्टको गर्छ। ओके। र अनि तपाईँको हातको के फुस्केको जस्तो पहिला जुन चाहिँ डह्रो गरी समात्न सक्ने, अहिले त्यो हात चाहिँ अलिकति पावर कम भएको जस्तो छ, अलि लुलो जस्तो भएको छ। यस्तो समस्या पहिला कहिले भएको छ तपाईँलाई? गठिया बात छ। कति भयो गठिया बात भएको? रोमाटिक आर्थराइटिस भयो। कति भयो गठिया बात?
4 वर्ष जति भयो।
औषधि खाइराख्नु भएको छ? सो तपाईँलाई यो गठिया बात बाहेक अरू के प्रेसर, सुगर, थाइरोइड त्यस्तो कुनै छ? ल के छ भन्नु त? प्रेसर छ हजुरलाई, सुगर छ र थाइरोइड पनि छ। सो तपाईँलाई दीर्घकालीन रोग चाहिँ 4वटा भयो। एउटा गठिया बात, प्रेसर, सुगर र थाइरोइड भयो। त्यसमाथि पनि यो घाँटी दुख्ने, पछाडिको घाँटी दुख्ने, यसरी पिठो पनि दुख्छ होला, यो भाग पनि दुख्छ, दुखेर यसरी नै आउँछ होइन? यसरी नै रेडिएटिङ टु यही सबै आउँछ। पुरै झमझमाइरहेछ होइन? यो एकचोटि खोल्नु र स्वेटर पनि खोल्नु, म जाँच गर्छु। विश्व अङ्कल त मैले बच्चादेखि चिनेको मान्छे हो। अनि मलाई चाहिँ माजु माजु भनेर जिस्काउनुहुन्थ्यो कि उहाँले। अहिले बस्नुपर्छ। वेट कम बढी भयो हजुरको, सुगर प्रेसर यत्रो रोग छ।
सुगर प्रेसर छ, हिँड्न अल्छी गर्छु, टोल टेङ्गो भएर झन्डै मारेको थिएन।
यता विश्व अङ्कल कोरोनाले उडाइदियो।
विश्व अङ्कललाई कोरोना लग्यो, विश्व अङ्कलको बुहारीले टेङ्गोले झन्डै लाग्यो।
यसले जिउडाले यसो छोड्नुहोस् त, यसो गर्नुहोस् त। So I'm checking the range of motion of the neck. यसो गर्नु त, यो गर्दा के अप्ठ्यारो छ? के अप्ठ्यारो छ? दुख्छ। के गर्दा दुख्छ? अगाडि झुक्दा दुख्छ कि पछाडि गर्दा दुख्छ कि? यसो गर्दा चाहिँ यहाँ दुख्छ है त। म एकचोटि छामेर हेर्छु है त। मैले छामेको भाग दुख्यो भने भन्नुहोस्, दुखेको छ? धेरै दुखेको छ? यहाँनिर दुख्यो, यहाँ। So I'm palpating the area, occipital area, facet as well as neck muscles. She's having pain on the trapezius. दुखाइ यसरी नै तलसम्म आएको छ है। यो दुखाइ तपाईँको जुन चाहिँ अघि मका आउनुभएको दुखाइ चाहिँ यसरी आइरहेको छ यहाँसम्म र यो दुखाइ एकचोटि तलसम्म पनि गएको छ र यही दुखाइ सरेर यसरी तल आएको छ। तर मेन दुखाइ चाहिँ यो मैले छाम्दाखेरि है यहाँ पनि छ अलिअलि, तर यसमा त एकदमै धेरै छ है। म अब यसो गर्छु, म जबरजस्ती तपाईँको टाउको थिच्छु र त्यो टाउको थिचेको टाउकोलाई म पहिला यता देब्रेतिर लान्छु आफै। त्यो गर्दाखेरि हातको झमझमाउनी बढ्छ कि बढ्दैन हेरौँ है त। र त्यस्तै गरी पहिला देब्रे गर्छु र देब्रेमा पनि बढ्छ कि बढ्दैन हेरौँ है त। I'm doing spurling test. जबरजस्ती थिचेको हो, तपाईँले टेन्सन नलिनु है त। मैले थिचेको छु। यो दुखाइ तपाईँको घाँटीमा या हाततिर गएको छ? आयो होइन? तपाईँको यो हात दुख्न थाल्यो, आयो होइन? अब बिस्तारै कडा नगर्नुहोस्, त्यति कडा नगर्नुहोस्। यसो गर्दाखेरि तपाईँको हात तल झम्झमाउने गएको छ, आयो तलसम्मै आयो। कुन हात दुख्यो देखाउनुहोस् न, तलसम्मै आयो, औँलासम्मै आयो होइन? So she is having radiating pain in the right upper limb. आराम भयो, भयो यो हात दुखाइ कम भयो, कम भयो। ल अब म त्यस्तै गरी देब्रे साइडमा लैजान्छु है त। I'm checking the other side. अहिले यो हात दुखेको छ, घाँटी दुखेको छ? छैन। तर मैले यो यता लैजाँदाखेरि सुरु भयो होइन? सो यो हात यसो गर्नु त अब आराम हुन्छ कि हुँदैन हेरौँ। This is relief side. Okay. Just now I checked the Sperling's test and it was positive. Now I am checking the relief side. So she should have relief, pain relief in the hand after doing this. यसो गर्दाखेरि अलि कम छ दुखाइ, झमझमाउनी कम भयो हातमा, कम भयो। So she says that pain reduction has started once she places her hand over the head. So this is called relief sign. So this is a case came to me with neck pain with radiating pain to the hand, and I suspect cervical nerve impingement. The positive test was there was tenderness in palpation of the trapezius. Spalling test is positive, and relief sign is also positive. Now I am going to do neurological examination of the patient. That means I will be checking the sensory, motor, and the reflexes of both hands. Okay. The range of motion of the neck is normal. There is tenderness in the right-sided trapezius as well as right-sided cervical facet area, the lower cervical facet area. यसो गर्दाखेरि कम छ हैन? कम छ. अब यसो यता अलिक फर्किनुहोस् न. हातको माथि लाग्नुहुन्छ, यो दुईटै हात माथि लाग्नुहोस् त, यो कपडा यसो. मैले यो छोएको र यो छोएको चाल बराबर छ कि फरक छ दायाँ र बायाँ? बराबर छ है. सेन्सरी एट द लेभल C6 इज नर्मल. के त बराबर छ हैन? र यो भागमा चाल बराबर छ कि फरक छ कि? बराबर. ठिक छ. अब यो कुमलाई यसो माथि लाग्छ. I'm checking motor of C4 माथि यसो. हो ठिक छ. अब यसलाई हातलाई यसो बाहिर लानुस् त. यसरी. ओ गर्नु लानु बाहिर लानु भयो. ल दिस इज फर C5. अब यसो च्याप्नुस् त. च्याप्नु. ठिक छ. अब यो हातलाई आफू तान्नुस् त. तान्नुस्. ठिक छ. अब यो हातलाई सिधा गर्नुस् त. सिधा यसो ठेल. अहिले हैन. ठेल्नु त. ठिक छ. यो ठेल्नुस् त. ठेल्नु. So I'm doing motor examination of C6. This is for C7. This is for C8. Motor function is normal. All C4, C5, C6, C7 and T8. C8. All motor functions are normal. Now I'm going to check reflexes. We start with the checking the supinator reflex. Reflex is normal. Here the reflex is slightly blunt in the right side. Current line in the झट्का line तपाईलाई. यहाँ पनि झट्का जस्तो लाग्यो हैन? झट्का लाग्यो यसमा पनि. सो मैले जाँच गर्दाखेरि चाहिँ मेरो विचारमा चाहिँ तपाईको चाहिँ घाँटीमा नसा च्यापेको जस्तो सामै. र त्यो घाँटीमा नसा च्यापेको मान्छेलाई चाहिँ यो घाँटीको यो भाग दुख्ने र यो पिछुको पछाडि र हात यसरी दुख्दै आउँछ है. तर मेरो अनुमानमा चाहिँ तपाईको बुढी औँला र यी औँलाहरू धेरै झम्झमाउने, फोल्ने, लाटो हुने र यो दुख्ने भएको भएर मेरो अनुमान चाहिँ घाँटीको 6 नम्बर र 7 नम्बर नसामा चाहिँ तपाईको यो दुईटा हड्डी भयो. यो घाँटीको जुन चाहिँ दुईटा हड्डी हुन्छ, त्यो दुईटाको बिचमा एउटा कुरकुरे हड्डी हुन्छ. त्यो कुरकुरे हड्डी यसरी निक्लिएर तपाईको यो नसालाई चाहिँ यसले यसरी यो नसा चाहिँ हातमा जाने नसालाई चाहिँ यसले छुइरहेछ. र त्यसले गरेर यो समस्या भएको हो. समस्या यहाँ होइन. समस्या चाहिँ यहाँ छ. र जुन चाहिँ तपाईले यो चाहिँ एक्सरेमा देखिँदैन. एक्सरेमा चाहिँ हड्डी खिएको मात्र देखिन्छ. तर एमआरआईमा चाहिँ यो कति खिया छ, कति नसा च्यापेको छ, सबै देखिन्छ है. र नर्मली यो रोग चाहिँ 80% मान्छेलाई आफै कम भएर जान्छ. 2-3 महिनामा बिस्तारै कम भएर जान्छ. तर त्यो 2-3 महिना चाहिँ तपाईले के गर्नु पर्यो त? एक नम्बरमा चाहिँ घाँटीको फिजियोथेरापी, जस्तै यो घाँटी बलियो गर्ने एक्सरसाइज है, यसो गर्ने, यो यसो माथि लाने, यो घाँटी यसो गर्ने, यो फिजियोथेरापी चाहिँ रेगुलरली गर्नु पर्यो हजुरले है. त्योसँग 2 नम्बर के गर्नु पर्यो त? टाउको धेरै झुकाएर मोबाइल हेर्नु भएन, या रोटी बेल्नु भएन. घाँटी जस्तै तपाईलाई हेर्नु, मैले टाउको थिच्न सक्दैन, यसो गर्दाखेरि यो हात यतातिर झम्झमाउनु थाल्छ. त्यही भएर तपाईले चाहिँ टाउको झुकाएर मोबाइल हेर्ने या केटी मान्छे त घरमा त घरको काम गर्नु पर्यो, जस्तै रोटी पेल्नु पर्यो, लुगा धुनु पर्यो. त्यो गर्दा धेरै टाउको नझुकाउनुहोस्. र तपाईको सुगर कन्ट्रोलमा छ कि छैन? सो अहिले चाहिँ म तपाईलाई चाहिँ यो नसा झम्झमाउने कम हुने औषधि राखिदिँदैछु र फिजियोथेरापी गरौँ र लो डोज एउटा स्टेरोइड राखिदिँदैछु. त्यसले अलिक कम हुन सक्छ. त्यसले पनि कम भएर चाहिँ हामी घाँटीमा चाहिँ सुई दिनु मिल्छ. तर सुई दिनुभन्दा अगाडि चाहिँ एमआरआई एउटा गर्नुपर्छ, कति च्यापेको छ। अनुपातको भरमा सुई दिन मिलेन नि त, हजुरको भरमा है। एकचोटि यहाँ यता पनि देखाउँ न, यता हेर्नुहोस् त, तपाईँको चाहिँ समस्या के भयो भने घाँटीमा है सर्भाइकल एक्सहर्निएसन। सपोज तपाईँको चाहिँ यो यता हेर्नुहोस् है, एकछिन है, तपाईँलाई मैले देखाएँ। तपाईँको यो घाँटीमा यसरी तपाईँको घाँटीमा चाहिँ नसा च्यापेको छ, त्यसले गर्दा यो दुखाइ चाहिँ घाँटीको तल, घाँटीदेखि यसरी सरेर हातमा हेर्नु, यही ठाउँमा तपाईँको यो बुढी औँला र यही तपाईँ देखाउनुहोस् त कुन औँला हो, यति हेर्नु त, यो फोटोमा पनि त्यति नै देखिरहेको छ। र तपाईँले अहिले जहाँ सुनसुमाइराख्नु भएको चाहिँ यो ठाउँमा कट गर्नुहुन्छ र अर्को चाहिँ यो ठाउँमा दुख्छ, यो ठाउँमा है। सो के भयो भने तपाईँको चाहिँ यसमा अलिक फोकस गरिदिनु है, यसमा यस्तो हुनुपर्ने, यही भयो तपाईँको यो हड्डी होइन। यसमा चाहिँ यो चाहिँ भित्र चाहिँ एउटा टुथपेस्ट जस्तो या लेदो पदार्थ हुन्छ, त्यो चाहिँ केही न केही बाटो मिलाएर यसले फकाएर बाटो मिलाएर यो नसा चाहिँ च्यापिरहेछ, बाहिर आएर यो नसा च्यापिरहेछ र तपाईँको चाहिँ यस्तो हुन्छ। हेर्नुहोस् है, सर्भाइकल रेडिकुलोप्याथी। अब तपाईँलाई चाहिँ के भइरहेछ भन्दाखेरि तपाईँले यसरी जाँच गर्दाखेरि यो चाहिँ फोकस गर्नु है। सो तपाईँले त खास मगा आउनुभयो त घाँटीको पछाडि च्यापेर, अगाडि होइन कि पछाडि होइन, यसरी हेर्नु त। तपाईँको मेरो शङ्का चाहिँ 6 नम्बर र 7 नम्बरको नसा थिचिएको छ। 6 नम्बरको थिच्दाखेरि हेर्नु, यो घाँटीको पछाडिदेखि दुखाइ आउँछ, यहाँदेखि दुखाइ आउँछ र यो बिजुको पछाडि दुखाइ हुन्छ र त्यही दुखाइ सरेर यो हातको औँला, बुढी औँला र यो छोरी औँला र यो 3टा औँलामा यसरी आइरहेछ। त मेरो शङ्का चाहिँ 6 नम्बर र 7 नम्बरको लेभल घाँटीमा चाहिँ हो, यसरी 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 यो नसा चाहिँ घाँटीमा च्यापेछ। ओके, र यो म अहिले दबाई दिन्छु र दबाई भन्दा पनि अर्को इम्पोर्टेन्ट काम भन्दा चाहिँ एक्सर्साइज, फिजियोथेरापी रेगुलरली गर्ने र टाउको धेरै झुकाएर काम नगर्नु। त्यो औषधिले यो सबै ठिक गर्यो भने केही गर्न चाहन्न, यदि त्यसले ठिक भएन भने चाहिँ म चाहिँ के गर्छु भने म अपरेसन गर्ने डाक्टर होइन, म चाहिँ तर एमआरआई हेरिसकेपछि है तपाईँलाई के गर्न चाहन्छु भने हेर्नुहोस् है, सर्भाइकल इपिड्युरल स्टेरोइड इन्जेक्सन भन्ने यो चाहिँ घाँटी हो। तर त्यो गर्नलाई चाहिँ तपाईँको यो इन्जेक्सन दिनलाई चाहिँ तपाईँको सुगर नर्मल हुनुपर्छ, किनभने यो स्टेरोइड भन्ने औषधिले सुगरलाई बढाइदिन्छ, त्यही भएर सुगर चाहिँ नर्मल हुनुपर्छ। हेर्नु त, यसरी म तपाईँलाई यसमा चाहिँ देख्नु भएको छ तपाईँले घाँटीमा नसा च्यापेको यहाँ हो नि त। तपाईँलाई अपरेसन कोठामा लगेर एक्सरे हेरेर यो सुई देख्नु भएको छ, यो सुई दिएर यो घाँटीमा जहाँ नसा च्यापेको छ घाँटीमा त्यो ठाउँमा सुई दिन्छौँ यसरी। जस्तै यहाँ पनि देख्नुभयो, यहाँ त सुई देख्नुभयो, यो सुई चाहिँ यहाँ घाँटीमा नसा च्यापेको छ तपाईँको, यसरी सुई दिन्छौँ र यो चाहिँ अन्दाजको भरमा सुई लाउने होइन, यसरी तपाईँलाई अपरेसन कोठामै लैजान्छ। हेर्नुहोस् है, यो सर्भाइकल इपिड्युरल स्टेरोइड इन्जेक्सन भन्ने हो। यो चाहिँ तपाईँलाई यसरी यसरी सुई चाहिँ देख्नुभएको छ, सुई यो चाहिँ मूल नसा यो भयो, यो मूल नसाकै नजिकै सुई दिन्छौँ र तपाईँलाई यसरी अपरेसन कोठामा लगेर एक्सरे हेरेर र एक्सरेको आधारमा सुई दिने हो। यो चाहिँ औषधिले भएन र एक्सर्साइजले भएन। ओके, नत्र पर्दैन। यो लगभग 80% मान्छेको यो रोग आफै बिस्तारै कम भएर जान्छ। तर त्यो गर्नलाई तपाईँले पनि विचार गर्नु, तपाईँ टाउको धेरै झुकाउनु भएन, एक्सर्साइज घाँटी बलियो गर्ने एक्सर्साइज चाहिँ रेगुलरली गर्नुपर्छ है हामी हो। त्यो यसरी 10 चोटि यसो यसो। अरू के गर्नुहुन्छ त्यो बाहेक? अरू अरू अझै पुगेको छैन, अझै पुगेको छैन। अझै यहाँ पनि फिजियोथेरापिस्ट बहिनी हुनुहुन्छ, आउनु भएको छ आज फिजियोथेरापिस्ट अझै पुगेको छैन तपाईँको। त्यो भएर पाटन हस्पिटलमा जानुभयो पनि हुन्छ फिजियोथेरापी गर्नलाई। फिजियो र औषधिले भएन भने चाहिँ सुई लगाउनु पर्यो, तर सुई लगाउँदाखेरि सुगर नर्मल हुनुपर्छ तपाईँ। ओके, तपाईँको घाँटीमा नसा च्यापेर यो हातसम्म आएको घाँटीमा र तपाईँलाई दुखाइ पनि ठ्याक्कै यस्तै छ। हेर्नु त, यो रातो 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 भाग जहाँ जहाँ छ हेर्नु, तपाईँलाई दुख्ने ठाउँ यही हो, एक्ज्याक्टली यही हो भनेको 6 नम्बर या 7 नम्बर नसा चाहिँ च्यापेको यही हो, ठ्याक्कै यो छ है। Okay, so just now you saw the examination of a patient. I'll be sharing you the screen regarding the summary of the So is the screen visible, sir? Hello, is the screen visible?
Yes, sir.
Yes, sir.
Okay. So just now you saw a patient with a neck pain who came to my clinic with a radiation of pain to the arm up to the fingers. So I'll be it is I have diagnosed that patient with cervical radiculopathy, and I have started the conservative management. Let's see what are the issues. Okay, so this is the summary of the patient. A 60 years old female came to the clinic with neck pain and hand pain for last 2 months. Regarding the history of present illness, she had a sudden onset of neck pain and upper back pain since last 2 months, which was deep aching in nature, and that pain was radiating from the neck and upper back to the right upper limb up to thumb and index finger as well as middle finger. Okay, and the radiating pain was burning, tingling in nature with numbness and slight weakness. Okay, and currently, initially, neck pain was more than hand pain, but when she came to pain clinic, hand pain was more than leg pain. The numerical rating score was 8 maximum, and when pain was less, it was 2. The pain was aggravated by cough, heavy work, and at night, and it was relieved by partially relieved with rest and by putting the hand above the head. She has rheumatoid arthritis for last 4 years. She is hypertensive, diabetic as well as hypothyroid, and she was taking all various oral medication for above condition. On examination, she had brought the C-spine X-ray, which was normal, and her blood test HbA1c was 7.4, which was slightly high. On general examination of the neck, the range of motion while checking range of motion, the right lateral rotation was painful. On palpation, tenderness was there in the right trapezius as well as in lower cervical facets. In special test, we did Sperling test, which was positive. Relief sign was also done, which was positive. And on neurological examination, motor of all C4 to C8 was normal. Sensory was also normal, but the reflex of right bicep reflex was slightly diminished in the right side. So we diagnosed the case as cervical radiculopathy, secondary to disc prolapse at the level of C6, C7 with right C6 and mainly C7 radiculopathy. So since the pain duration was less, it was subacute 2 months. So we started her in anticonvulsant, that is pregabalin 75 milligram 2 times a day. I have prescribed her for 60 days, and I've told her that this may cause slight sedation. There can be swelling of face or body, or some allergic reaction might be there. If such things are there, to call me immediately. And I have advised her, since there was no red flag in her, so conservative management was started, and I have advise her to change her lifestyle, avoid excessive neck flexion, and restrict screen time of mobile. And also had advised her to go to physiotherapy for additional neck physiotherapy, mainly neck isometric exercises. And I have called her after a month. If the conservative management fails or if it is inadequate, we are planning to do MRI of C-spine of 3 Tesla, and if required, we are planning to go for cervical epidural steroid injection, provided she has a normal blood sugar at that time. Okay, with this short history, let's go to the cervical radiculopathy. Okay, so there are two conditions in cervical, any pain like cervical. There are the cervical radicular pain and cervical radiculopathy has been used synonymously in most of the time, but actually cervical radiculopathy differs from cervical radicular pain. In cervical radicular pain, there is only pain. So there is shooting, burning, or electric shock like pain, which is usually perceived by the patient in the upper extremity, which can be radiating from the neck
due to the irritation of the cervical spinal nerve or injury of the cervical spinal nerve. So in cervical radicular pain, there is only pain, but in cervical radiculopathy, in addition to pain, there will be other neurological sign, which can be a motor system can be affected, sensory can be affected, or the reflexes can be affected. If neurological examination is normal, then it is called cervical radicular pain. If there is only positive neurological finding, sensory weakness, motor weakness, or sensory impairment, or reflex impairment of the reflex, then we diagnose the case as cervical radiculopathy. Though it has been used synonymously in most of the books and literature, but there is a difference between radicular pain and radiculopathy. But most of the time, these radicular pain usually proceeds to the radiculopathy. So initially there will be radicular pain, which gradually proceed forward as a radiculopathy. Okay, and causes for the cervical radicular pain and cervical radiculopathy is almost similar, and they may have same clinical entities, such as this condition basically occurs when there is a cervical disc herniation, or if there is a cervical lateral foraminal stenosis, or if there is any radiculitis secondary to arthritis, infection, or inflammation. Okay, so regarding incidence of cervical radicular pain, or mainly cervical radiculopathy, the recent data are not there, but I have posted a data which was a long way back. It was done, epidemiological data was done in Rochester, in Minnesota, USA, from 1976 to 1999, and the sample size was between 13 to 91 years of a patient, and they have found out that in every 100,000 population, 83 people were having the cervical radical pain, and incidence was highest between the age 50 to 54, and the most frequently involved cervical spinal nerve was C7, which accounts for 45 to 60%. More than 50% usually C7 nerve is affected, which is usually secondary to prolapse of C6 C7 cervical disc. And second was most common was C6 radiculopathy, which involves about 20 to 25% cases, and C5 and C8 is the least affected, that is 10% of cases. So here, as you can see in the picture, here you can see the disc height has been reduced. There are like degenerative changes in the C spine, and you can also see the disc bulge, which is impinging the cervical spinal nerve. So this is mainly regarding the epidemiology of the cervical radiculopathy. So regarding cervical radicular pain, so normally if C7 is irritated or injured, patient have pain basically confined to neck and suprascapular region, so it doesn't radiates to the arm. But as shown in the picture, if there is impingement of C5 nerve, you can see pain radiates, starts at the neck and the mid scapular region, and it radiates to the upper arm up to the elbow. Okay, so the red line is basically radiation of pain. So if there is impingement of C6 cervical nerve, here neck pain along with the intrascapular region pain will be there, but the radiation of pain will extend down to the thumb, and mainly thumb and the index finger. Similarly, if there is an impingement of C7 nerve, the pain will be perceived in the neck, upper back, as well as it basically radiates down to the middle finger, index finger, and ring finger. Okay, and finally, in case of C8 radiculopathy, the neck pain as well as upper back pain will be there, and the pain will also radiate from arm and forearm up to the little finger, as well as ring finger and the index middle finger. Okay, so pain from various dermatome, basically I have shown you the dermatological pattern of various nerve. So these pain from various dermatome may overlap, and there is no specific region of the arm which is basically says that there is a characteristic for particular segment of pain, but the area which is shown in the red marking, they are the predominant site of radiation of pain. And this radicular pain is not only limited to the skin, okay, not only limited to the dermatome, but it can be perceived to all the structure that the nerve is supplying. So they can have pain in the muscle, joint, and ligament, as well as skin, which is supplied by the particular nerve. Okay, so it is not only in the skin that the patient is having pain, but the nerve which supplies to the muscle, joint, and ligament, that will also be painful. Okay, and regarding the history, they might have history of acute or chronic neck sprain or strain. Normally, the aggravating factors are basically forward flexion or lateral neck bending. Usually, coughing, sneezing, and lifting heavy objects usually aggravates pain. And pain is usually relieved by putting hand over the head, which is known as relief sign. And it is also relieved by anticonvulsant, non-steroidal anti-inflammatory drug we can give, and physiotherapy plays an important role while patient is managed conservatively in basically in acute and subacute cases. And regarding physical examination, always we start with range of motion of the neck. So normally flexion and especially lateral rotation of the neck can have pain. There can be tenderness in the trapezius, affected sided trapezius, as well as lower cervical facets. On neurological examination, there can be impairment of motor, sensory, and reflexes depending upon the degree of impingement. And if you go for special test or any additional test, these tests are Sperling test, relief sign, which is also known as shoulder abduction test, and axial manual traction test are also done. So these are the special tests, and the specificity of these tests are about 81 to 100%. But these tests have a very low sensitivity. Okay, so this is the picture where Sperling test has been done. The test is done by putting axial pressure over the head, and the neck is extended or flexed, and it is rotated to the affected side shoulder. Okay, so when doing this, if we flex or extend the neck and just turn the head towards the wherever the whichever arm is giving pain, the pain is reproduced. Okay, as you saw in that patient also, while doing Sperling test, pain radiated to the right arm up to the thumb and index finger. Though the specificity of the test is 93% and sensitivity of the test is 30%. Though, so since the sensitivity of the test is just 30%, this Sperling test cannot be used as a screening test for all the patient who is having cervical radicular pain or radiculopathy. So next test we are doing is relief sign or shoulder abduction test. So in those patients who are having pain, radiating pain in the arm, we basically tell the patient to lift the hand and put it over the head. So the test is positive when this results in decrease or disappearance of the radicular symptom, as saw in the picture also. When that lady put her hand over the head, the the symptoms like radicular pain subsided a bit. Okay, so she also said in the history that in night she usually sleeps like that, putting her hand over the head because of the pain, and her pain was aggravating at night. Okay, so the third test we usually do is axial manual traction test. So in this test, basically patient is placed in supine position and axial traction force is applied towards you, and we basically at about 10 to 15 kgs. And in positive finding, basically when we apply we give traction to the head of about 10 to 15 kg, there should be disappearance or decrease of the radicular symptom. So these are the special tests which are done in the if we suspect any nerve impingement. And definitely we have to go for the neurological test also. So neurological characteristic of cervical radicular pain I have given in this chapter, in this part, in this slide. As you can see, if there is a prolapse of C4 C5 discs, so normally C5 nerve will be affected, and usually pain characteristic of pain I have already described in the medial scapular border and lateral upper arm up to the elbow, and they might have a weakness of deltoid, supraspinatus, and infraspinatus. And usually they can also have a sensory loss in the lateral aspect of the arm, and supinator reflex is usually impaired if there is impingement of C5 nerve root. Similarly, if there is impingement of C6 nerve root secondary to disc prolapse of C5 C6, then the radiating pain will radiate up to the thumb and index finger. And normally we can see weakness of biceps brachioradialis and weak and the wrist extension, and sensory loss can also be appreciated at the area of thumb, index finger, and over the arm where the pain is. And we can also sometimes get decreased reflexes of the bicipital reflex as seen in that patient. Okay. And if there is a cervical C7 nerve root impingement secondary to C6 C7 disc prolapse, the pain will radiate up to the dorsum of the forearm and third finger and middle finger. And we can see weakness of triceps or wrist flexors or finger extension. And we can also appreciate sensory loss in the posterior forearm, and there can be decrease or loss of tricep reflexes. Similarly, in case of C8 nerve impingement, which is only 10% of cases, there can be pain in the shoulder as well as in pain in the ulnar side of the forearm and fifth finger, that is little finger. And in case of motor weakness, thumb flexor and abduction and intrinsic hand muscle can have a weakness. And there can be sensory loss in like little finger as shown in this picture. There is a sensory loss, and usually reflexes are not involved in this. Okay, so this is basically examination finding you might appreciate in patient with cervical radiculopathy depending upon the extent of disc prolapse and nerve impingement. So regarding the investigation that we commonly do, normally checks cervical spine X-ray is done in cervical, and MRI of C spine is done. Normally in C spine X-ray, it can be normal, or sometimes there can be decrease in disc height of the level which we suspect of the radicular pain is. Normally there can be C5 C6 disc decrease in the height of the C5 C6 disc, or C6 C7 disc height can be reduced. Sometimes we can see the osteophytes and degenerative changes in the C spine X-ray, but in MRI also we can see. MRI is the gold standard test where we can see ideally how the disc has come out, whether it's a central, paracentral, foraminal, or extraforaminal, and what is the extent of the compression. In MRI, additional changes of the myelopathic changes can also be seen, which is a red flag. If there is any symptoms of myelopathic changes in the MRI, or if it is in the clinical examination, if you suspect cervical myelopathy, then it is a red flag which we have to refer to neurosurgeon for the possible surgery. But you have to understand that there is no direct link between basically pain syndrome and imaging modalities. Okay, like Gautam sir always sir tells us that we are not treating the MRI, but we have to treat the symptoms of the patient. So normally, if you see, they have done the prospective studies of this MRI in a normal healthy individuals also, and it has shown that in about 19% to 28% of the time in asymptomatic patient also they have found out disc prolapse is there. So we are not treating the MRI, but we have to treat the patient. So we basically, MRI can, even in the normal patient we can see the disc prolapse which can be completely asymptomatic. Okay, so these are the main two tests that is done. The cervical spine X-ray as well as MRI is the gold standard. Sometimes nerve conduction test is also done. So if there is any doubt whether this radicular pain is caused by the neurologic or any other cause like disc prolapse or other neurological causes such as like diabetic neuropathy or other impingement of the nerve apart from the disc bulge, then we can send the patient for nerve conduction test. But nowadays, like quantitative sensory test is also gaining its popularity. So the problem was with nerve conduction test was nerve conduction test gave more information regarding the nerve which is damaged, which usually didn't give any information regarding the pain of the patient. So nowadays, quantitative sensory testing are also done, which provides us more information regarding the pain and as well as nerve damage. So this quantitative sensory test basically it detects if there is any problem for light touch or allodynia, it can easily detect, and it can be a valuable tool for the examination and for the investigation as well as for the treatment. Okay, so another investigation we can do is a diagnostic selective nerve root block. So this diagnostic selective nerve root block is usually given nowadays. We give under the ultrasound. Previously they used to give under the fluoroscopy guidance, but I'll be talking with this talking later on regarding various disadvantages and complication associated with fluoroscopy guided diagnostic selective nerve root block. Nowadays we do all this procedure under the guidance of ultrasound. So if the patient comes and if you suspect a C6 radiculopathy or C7 radiculopathy and you want to be sure, okay, or if the patient is having severe pain and you want to relieve the pain, in those conditions also you can simply take a ultrasound and scan the neck and find out C6 or C7 or C5, whichever nerve root is giving a problem due to irritation. And for temporary relief or for the diagnostic purpose, we can inject local anesthetic as well as soluble steroid in the area around the nerve, which can take care of the pain, or it can be of diagnostic value. If the nerve which we think is giving pain and after the blocking patient's pain has reduced, then that can be a diagnostic test also. Okay, so this is the typical x-ray that we can see in the patient with cervical disc prolapse. As you can see here, the upper, this is the C2 cervical vertebra, this is C3. You can see the disc height is normal. C3 and C4 also disc height is normal, but C3, C1, C2, C3, C4, C4, C5, C5, C6, and C6, C7. You can see three levels. You can see decrease in disc height. So this can be a X-ray finding in patient with disc prolapse. Here, there we can expect multiple level disc prolapse in these cases, and you can also see the degenerative changes in the spine, which is seen as a osteophytes. Okay, coming. So here you can also see disc height has been reduced. This thing can be appreciated in patient with disc prolapse with cervical radiculopathy. So this is the MRI picture of the patient with typical MRI picture. Here you can see in the sagittal view, you can see there is a disc bulge which is compressing which is impinging the anterior thecal sac, and C1, C2, C3, C4, C5. So see this C4, C5 level nerve impingement is there. So this is the axial section. Here also you can easily see there is a paracentral disc protrusion causing impingement of the nerve, usually the traversing nerve. You can see this. So this is the typical finding of the patient in the MRI in those patients who having the radicular pain secondary to cervical nerve impingement. So this is the basically nerve conduction test of the upper limb. If you have any doubt regarding the MRI is normal, you can go for the nerve conduction test or quantitative sensory testing. So this can be also a valuable tool. Another thing is, here you can see in the picture, this is the ultrasound examination of the cervical nerve root. Here I have given the picture of C6 and C5 nerve root. Here you can see this is the C6 nerve, cervical nerve root. How we can know this is C6? Because here the anterior tubercle is big. So this is the Cassinac tubercle. So on ultrasound you can see a prominent anterior tubercle at the level of C6, and this is the nerve, and these are the few vessels. But the main vessels we will be worried about is the vertebral artery, which is usually inside the foramen in this level. And this left-sided picture is of the C5 nerve root. I have given both the picture because just to compare, for you to see the and compare between the anterior tubercle of C6 and C5. Okay, so with ultrasound we can identify each nerve, cervical nerve root, and we can inject the individual nerve as a diagnostic and therapeutic purposes also. In the lower part of the picture you can see a needle coming from here in plane. Needle is coming from lateral to medial side and injection being given. So this is how we can block the nerve individual selectively. Cervical nerve can be blocked as a diagnostic test. Okay, so regarding the treatment, we usually, if the problem is acute or subacute, we know that disc prolapse of 70 to 80% of cases it resolve by itself. Okay, so basically we have to why it resolves, because the nucleus pulposus which is inside, which should be inside, is coming out due to various reason, and it is impinging the nerve. But the thing is, this nucleus pulposus is the extra embryonic, so in structure. So when it comes out, our body will think that it is a foreign body. So like any other foreign body, our body will try to eliminate it and eat that or everything which is come out. So normally in 70 to 80% of cases, this will be resolving by itself by 4 to 6 weeks, or maximum by 6 to 8 weeks. Gradually, pain and other symptoms will subside in 60, 70 to 80% cases. But sometimes it is not so, and in those cases we have to go for the intervention management. But generally, in case of acute and subacute cases, like the lady that came to the clinic, we would like to go for the conservative management first. And but here you have to, before starting the conservative management, you have to be sure that there is no red flags. Okay, red flags means if the motor weakness is more than 3/5, or if the sensory impairment is more than 50%, or if there is sudden increase in sensory impairment, or if there is any cervical myelopathic signs of the reflexes are being hyperreflexia is there, or if there is any bowel or bladder problem, then these are the red flags. Okay, so in these condition, or if there is any tumor impinging the cervical nerve in the MRI, so these are all red flag. In these red flags, we are not waiting for a conservative management. We have to send the patient to the refer the patient to the concerned this doctor's super specialty for further management. So if these red flags are not there, and if the condition is acute or subacute, we usually treat them with non-steroidal anti-inflammatory drugs and anticonvulsant. So drug of choice is usually pregabalin, initially pregabalin, or we can also give gabapentin, or also, and we can also start with amitriptyline depending upon the cases. Normally the dose of pregabalin is, we usually start with 50 milligram, gradually titrate the dose to 75 milligram, or if required we can go up to 150 or 300 milligram. Similarly, if it's not adequate, we can also add amitriptyline 10 milligram or nortriptyline if there is no contraindication. And with these medication we can manage conservatively. Okay, and rehabilitation and physiotherapy also plays a vital role. So in my part of the world, people think that only with physiotherapy it helps. So if you send the patient to physiotherapy, there can be two benefit. One is physiotherapy is also various physiotherapy maneuvers are there to decompress the nerves, and they will also have a psychological benefit that I'm doing exercise, and exercise will also help me reduce the pain. So rehabilitation and physiotherapy is also vital while we wait for the spontaneous recovery. And in the during this time, we have to tell the patient to avoid, we have to tell the patient to do lifestyle changes, like avoid excessive forward flexion or bending, or lifting heavy object within this period of time. Okay, so even after waiting 4 to 6 weeks, if the pain is not relieving, or if the pain is very severe, and some people would want to wait up to that period, then we can go for the intervention management. So for the intervention management, the choice of intervention is, first choice will be the interlaminar cervical epidural steroid injection. Okay, so that is the first choice. In my patient also, if the patient is not getting better with conservative management, our plan is to go for cervical epidural steroid injection. Okay, so here the main thing is injection of the steroid, which will decrease the inflammation, and it is also taking care of the neuropathic pain also. But in my part of the world, many orthopedician or many other doctor usually give oral steroid, or sometimes they can also the people have a wrong practice of injecting like steroid. I am sure in your part of the world people do that, intramuscular steroid injection and oral steroid, prescription of oral steroid while the patient is managed conservatively. Okay, so there has been a study regarding this. So they have found that interlaminar cervical epidural steroid injection gave 68% better outcome compared to 12% in those cases who is having intramuscular or oral steroid injection. So this is one very nice study. So this all studies also tell us that though we are giving steroid in different form, okay, directly into the epidural space, this has more better outcome than giving patient orally or intramuscular steroid injection. Okay. So next option, intervention pain management, they used to do in past about 10, 15 years back or even 8 years back was transforaminal cervical epidural steroid injection. So if you study some book, they also recommend giving transforaminal cervical epidural steroids injection, but it is absolute nowadays due to various complications. So that's why I have given this in red mark. But sometimes if you study a book which is older book, like they recommend giving transforaminal cervical epidural steroid injection. But nowadays it is absolutely contraindicated due to the various complication. I'll be showing you the various complication it has. So another step that can be done is we can also go for a could in the previous days they used to give low temperature about 40 degree to 67 degree conventional radio frequency ablation of DRG was also given if the cervical epidural steroid injection is not relieving pain. Okay, so it is also not done nowadays because of various complication, mainly because of the weakness of the muscles of the arm. Okay, so and the other intervention we can go for is pulse radio frequency of dorsal root ganglia of the nerve which is causing problem. We can identify the nerve which is causing problem by giving the selective cervical nerve root block. So if you see the recent guidelines, cervical radio frequency of DRJ has a highest evidence of 1 B plus. Okay, so if the cervical epidural steroid injection is not relieving the pain, or if the patient is not willing to go for surgery, and if there is no red flag, the next step would be after cervical epidural steroid injection would be a diagnostic cervical selective cervical nerve root block. And if the diagnostic block is positive, then we can go for pulse radio frequency ablation of the nerve which is being irritated. Okay, and if there is any red flags, or if the patient is having refractory pain, or if they are having any cervical myelomalacia, then surgical treatment can be done. And if none of the above intervention is relieving pain, then spinal cord stimulation is the modality of the choice. Okay, so summarizing the intervention pain management, what we do nowadays is we first go for, after doing conservative management, we go for the cervical epidural steroid injection. Okay, and if that is also not relieving, then we go for the diagnostic cervical selective nerve root block. And if the diagnostic block is positive, then we go for we pain physicians go for the pulse radio frequency ablation of DRJ of the nerve which is causing problem. If that is not also helping, then only patient is going for the surgery, or if there is any red flag or myelomalacia, or if there is none of the above technique is giving relief, then spinal cord stimulator is the treatment of choice in these group of population. Okay, so let us see about the. Okay, so this is the picture of cervical epidural steroid injection that I did in my patient, previous other patient, not this patient. As you can see, this is the I have put the needle between the T1 and C7. This is the ideal place. Here you can see the epidural needle going into the this epidural needle into the epidural space after checking loss of resistance and after confirming the epidural space by dye. Then in this after the dye we give the steroid. So normally you may think which steroid to give. Nowadays usually non-particulate steroids are given in the neck and in the head and neck region, basically due to the various complication of the particulate steroid. We are giving a non-particulate or soluble steroid in this region. We can give Dexona, about 4 to 8 mg can be injected, or sometimes triamcinolone acetate, though it is a particulate steroid, because this triamcinolone acetate has a smaller particles. We can go for the if you are planning to give particulate steroid, then triamcinolone acetate is the best. But the recent guidelines suggest to use the soluble steroid in the head and neck region for epidural or any other steroid injection. So this is the typical picture of the cervical epidural steroid injection. If this is not helping, then we can go for, this is also the picture of the cervical epidural steroid injection and transforaminal cervical epidural injection. As you can see in this picture, if you can see the transforaminal region, there are lots of vessels near in the transforaminal region. Okay, but if you see in the cervical region, there is not too many vessels in. So this interlaminar cervical epidural injection is quite safe if you see this picture. But if you see the transforaminal injection, you can see there are lots of vessels nearby in the foramen. So because the vessels are very small, some vessels are some vessels are big. So injection of this transforaminal region is absolute nowadays because of lots of complication associated with, mainly intravascular injection can happen, which can sometimes it cannot be detected by the dye. So various studies has been done. I'll be showing you the result of those studies also. So those studies shows that various life-threatening complication associated with transforaminal cervical epidural steroid injection. So this procedure is avoided. Now we are going through the cervical interlaminar cervical epidural steroid is given nowadays. Okay. So this is the picture of pulse radio frequency done. So here you can see the radio frequency needle in the middle and lower part of the foramen, because the nerve is located in the cervical region, is located in the lower part of the foramen. And here this is the lateral view. This is the lateral view. You can see the radio frequency needle, and this is the pulse radio frequency, the classical picture of the pulse radio frequency of the cervical spinal nerve root. And this, if none of these modalities is helping, then this insertion of the spinal cord stimulator in the posterior aspect of the epidural space is the treatment of choice in those patients with refractory neck and hand pain in this condition. Okay, so regarding the complication, so interlaminar epidural steroid injection has some risks. It is in some books it is written that the risk is less than 1%, and in some books it is said that risk is about 16 to 8%, depending upon the various book. But the range is 1% to 16%. So majority of the complication are minor complications, such as axial neck pain can be there. There can be posture independent headache can be there. There can be flushing of face. There can be vasovagal episode, but these complications usually subside within 24 to 48 hours. Okay, but having said that, it also has some major complications, such as epidural hematoma can be there. Accidental subdural injection can be there. If that happens, then patient can be there can be hypoventilation and hypotension in those patients. Accidental subarachnoid injection can be there, which can be a bit dangerous. Apnea, cardiovascular collapse, and even death has been reported. So accidental intravascular injection can be there. That's why we are using soluble steroid instead of particulate steroid. We are not using particulate steroid because this particulate steroid acts as a emboli. Okay, so these particulate steroid can block the vessels, and especially if the small vessels of the head and neck is blocked, especially the vertebral artery. If it goes into the vertebral artery, it can cause infraction of the spinal cord or even the brainstem. So that can be a very dangerous condition, and that can be lethal and life threatening. Okay, and sometimes there can be damage to the spinal cord if you are not careful, and if you are not advancing needle too much, there can be a damage to the spinal cord. So these are the complications associated with interlaminar cervical epidural steroid injection. Now coming to the transforaminal injections, and why we avoid doing transforaminal epidural injection nowadays, because main thing is here the serious neurological complications are there, and these complications are usually fatal and life threatening, and there is increased chance of intravascular injection. As you saw in the picture, there are lots of vessels, feeding vessels, radicular vessel, which will eventually go to the vertebral artery and anterior spinal artery. Okay, so that can cause fatal outcome of the patient. And conventional RFA was also used in past, but nowadays it is less popular because of the complications such as neuritis can be a problem, or weakness of the hand can be a problem. So now better option would be pulsed RFA is gaining its popularity, and there has till now. So I don't know till now, but I have reviewed of 5 years back of literature, and they have said that there has been no reported major complication associated with pulse radio frequency ablation. Okay. So this is the slide which shows various complications associated with transforaminal injection. Okay, you can see I've circled this with the red mark. See the complication, and this study has been carried out from 2001 to 2007. Okay, here you can see in one patient there was like paralysis below C3 level for 1 minute, but the patient eventually died after 1 month. In second study, there was like 45 minutes of injection. There was apnea and nystagmus and agitation in that patient. Okay, and the patient was discharged after 30 days after the injection. In another case, there you say like that patient died on the day after the injection. Okay, there was loss of consciousness, and CT scan also showed hemorrhage around the brainstem, and in a few cases there was a weakness and feeling of weakness of all four limb, but it gradually resolved within 20 minutes. And in other studies, they also there was unresponsive and comatose for about 1 hour, and eventually patient woke up after 1 hour, but died in the next day. In another study in 2004, they said there was an anterior spinal artery syndrome, and this patient basically was more it took the patient 3 months for spontaneous respirator, and the patient was kept in ventilator for about 3 months. And in 2005, there was a study in which there was incomplete tetraplegia. So all these complications are very dreadful. We are very if any of this complication happens to us, then our career as a pain physician will be over. Okay, so and in another patient, the patient died shortly after the procedure. Again, there has been reported lots of fatalities and even death following the transforaminal cervical epidural steroid injection. So I request you everybody not to venture transforaminal cervical steroid injection, but go for the safer option, that is interlaminar cervical epidural steroid injection, and use soluble steroid. Okay, try to avoid the particulate steroid. So if you see the summary of evidence of intervention pain management, so they have given the interlaminar cervical epidural steroid corticosteroid injection. They have given the evidence level 2B plus. Okay, so but they have given negative evidence for the transforaminal cervical epidural corticosteroid injection. So it is 2B minus. Okay, so minus means you should not go venture for the transforaminal injection. So similarly, for the conventional low temperature radio frequency DRJ, the evidence they have given is 2B plus. But though the evidence is 2B plus, we are not doing nowadays because of the it can cause weakness of the arm, because the cervical spinal nerves are the mixed nerve, so there are motor component associated with it. So weakness of the hand means it is not desired by the patient as well as the physician. So nowadays, if you see the guidelines, pulse radio frequency of DRJ has the highest evidence, that is 1B plus. So if interlaminar cervical epidural is not helping, if the patient doesn't want to go for surgery, and if there is no red flag, you can go for pulse radio frequency ablation. Here Dr. Gautam Das frequently does this pulse radio frequency DRJ. And final, if none of the above is working, then spinal cord stimulation is the choice. Okay, to summarize, basically in subacute and acute and subacute phases, choice is interlaminar epidural. For chronic cases, go for pulse RFA is the first choice. Okay, and if all modalities fail, then spinal cord stimulation is the choice in these group of population. So this is also algorithm. Basically, to summarize it, if patients come with cervical radicular pain, we first have to avoid catch up the red flags. If there is red flag, we immediately have to send for the surgery or concerned super specialization. Okay, so if there is no red flag, then we can go for the conservative management for 6 to 8 weeks or about 6 weeks. If there is failure of any conservative management, then there are two if it is a subacute condition, we can go for interlaminar corticosteroid injection. But if it's a chronic condition, we can confirm the nerve root which is causing problem and go for selective diagnostic nerve root block, followed by if it is giving positive outcome, then we can go for pulse radio frequency of DRJ. If pulse radio frequency of DRJ is if the result is poor, or if the result is short lasting, then we advise patient to go for surgery or spinal cord stimulator. Previously they used to go for conventional RFA, low temperature conventional RFA. Here conventional RFA low temperature means about 40 to 60 degree Celsius, but nowadays we don't do it nowadays. Okay, so summarizing this all, so there is basically no gold standard for diagnosis of cervical test for diagnosing cervical radicular pain, and we basically diagnose this in the history and clinical examination are the main modalities of diagnosis. In terms of investigation, MRI is the preferred investigation of choice, and we usually send 1.5 and above Tesla power MRI is better for better picture quality. And if we suspect any nerve root, that suspicion can be confirmed with diagnostic selective nerve root block ultrasound guided. And when the conservative management fail, if it is subacute, we can go for interlaminar cervical epidural steroid injection, and in chronic cases we can go for pulse radio frequency ablation. And finally, if all modalities fail, then we go for the spinal cord stimulation. Okay. So thank you. So this is the case of cervical radiculopathy. Okay. So we'll do the discussion after the second case. Okay. So I'll be
Yes, Siris, you can go ahead with the second case, and then we can take the discussions as a whole about the neck pain and the radicular pain.
okay. So next case is very much interesting case. I think it will be very interesting for you all, and it can affect we everybody. So in today's, I'm in Daradia, and I asked a few of my fellows regarding this, and everybody is excited regarding this disease. So this is the recent disease, like this condition is termed as tech neck problem, because we are using laptop right now. I'm also using a laptop. We are hooked to the laptop. We are using smartphone regularly and tablet regularly. So in these group of people where we are using these technological aspect, and these technology with development of science and technology, lots of problem has started, and especially the neck pain is one of the most commonly associated problem when we are using smartphone or laptop and tablets. So I want to present a case regarding this and discuss the case regarding this. Okay, so there is a so let's share the screen.
नमस्ते.
Is the sound audible?
भयो होला.
Yes, sir.
Yes, Siris, it is audible.
कसो भयो? 25 वर्ष. के समस्या लिएर आउनुभएको सबिनाजी? घाँटी दुख्ने. कति भयो घाँटी दुखेको हजुरलाई? यो दुखाइ चाहिँ कस्तो छ त? मतलब कटकट खाने छ कि झमझमाउने छ कि पोल्ने छ कि कस्तो खालको दुखाइ हुन्छ तपाईलाई? कटकट खाने छ. अनि यो कटकट खाने दुखाइ चाहिँ तपाईलाई सुत्न भनेको दुख्दै नदुख्ने, दस भनेको यति धेरै दुख्ने कि अब तपाईँ अब हस्पिटलले गएर सुई लाउनु पर्ने खालको दुखाइ भयो नि. र यसमा चाहिँ जति नम्बर बढ्यो त्यति दुखाइ बढ्ने हुन्छ. तपाईलाई चाहिँ यो दुखाइ तपाईले आफैले मार्क्स दिनु पर्दाखेरि कति दिनुहुन्छ त यो दुखाइलाई? 7 to 8. दिनभरि 7 to 8 हुन्छ. दिउँसोको टाइममा चाहिँ धेरै दुख्छ, बिहान बेलुका चाहिँ. सो तपाईलाई दुख्ने भनेको बिहान दिउँसो बेलुकी समय दियो भने मेन दुख्ने नै दिउँसो मात्रै हो हैन. बिहान बेलुकी तपाईको घाँटी दुखाइ छैन, फ्रेस छ. र बिहान बेलुकी चाहिँ तपाईले जिरो नै हुन्छ कि दुखाइ अलिकति केही बसिरहेको छ कि कस्तो छ? भेरिएबल पेन छ हैन. तर दिउँसो चाहिँ तपाईलाई एकदमै बेसी हुन्छ. र तपाईलाई अनि के गरे भने आराम हुन्छ त यो दुखाइ? मसाज गरे भने औषधिहरु खाँदा. ओके. तातोले सेक्यो भने चाहिँ हिटले कम भइरहेछ, नदुखाउने औषधले कम भइरहेछ, मसाजहरुले कम भइरहेछ. र अनि तपाईँ के काम गर्नुहुन्छ? अकाउन्टमा हुनुहुन्छ. ओके. सो तपाईलाई अनि तपाईँ अकाउन्टमा काम गरेको कति भयो त हजुरले काम गर्नुभएको? 5 years भइसक्यो र त्यसै त कम्प्युटर त अहिले मात्र चला होइन होला तपाईँले 4-5 वर्षै भयो होला चलाएको 5 years भइसक्यो र अहिले के विशेष केही चेन्ज भएको छ कि तपाईँलाई के वर्क पोजिसन या तपाईँको या केही फरक भएको छ कि
पहिला चाहिँ डेस्कटप युज गर्थेँ सो अहिले नयाँ जबमा चाहिँ म ल्यापटप युज गर्छु
ओके त्यो एउटा चाहिँ हुनसक्छ सो तपाईँ पहिलादेखि नै कम्प्युटर वर्क त थियो तर पहिला चाहिँ तपाईँ डेस्कटप हुन्थ्यो पहिलाको जबमा तर अहिले यो जब चेन्ज गर्नुभएको कति भयो
जब चेन्ज गरेँ
1 year भयो र यो दुखाइ चाहिँ अहिले 2-3 महिना मात्र भयो
Sir, we cannot hear and see the screen. We can't hear you, sir.
Please,
So
you are
we can't
muted.
hear you, sir.
Okay, sorry. Shall I start from the beginning, sir?
Okay, you can start, or you can first initial few minutes we could understood. So you can slide the video, advance it video after first few minutes you can start 2-3 minutes.
Okay, sir.
नमस्ते यो ठाउँमा दुख्छ होइन यो दुखाइ सरेर तपाईँको हाततिर या पिठ्युतिर या टाउकोतिर आछ
Is it audible now?
टाउकोतिर चाहिँ अलिक दुख्छ यता साइड
Yes, it is audible.
टाउकोतिर दुखाइ आएको कति भयो त यो पनि 2-3 महिना भयो कि 2-3 हप्ता 2-3 महिना भयो र अनि तपाईँलाई कुनै बाथ रोगहरू घरमा या कसैलाई बाथ रोगहरू त्यस्तो केही छ छैन लड्नु भएको चोटपटक लागेको त्यस्तो केही छ छैन र तपाईँलाई मसाजहरू गऱ्यो भने आराम हुन्छ के गऱ्यो भने आराम हुन्छ सेक्दाखेरि आराम हुन्छ अरू नदुख्ने औषधि खाँदाखेरि मालिसहरू गऱ्यो भने चाहिँ कमै हुन्छ र ओके र यो दुखाइले गरेर के अब अहिले एभ्रिडे नै दुखाइ कम हुने औषधि खानु परेको छ तपाईँले एभ्रिडे नै खानु परेको छ र तपाईँलाई जस्तो बिदाको दिनमा सपोज अघि तपाईँले भन्नुभयो कि तपाईँ रिसेप्सनमा काम गर्नुहुन्छ र डे टाइममा धेरै दुख्छ भन्नुभयो र बिदाको टाइम छ अरे जस्तो अफिस जानु परेन भने पनि यो घाँटी टाउको दुख्ने हुन्छ कि कस्तो छ त्यो
काम गर्ने टाइममा चाहिँ
काम गर्ने
टाइममा चाहिँ अलिक कमै दुख्छ
अरू टाइममा चाहिँ कमै दुख्छ सो ठिक छ म एकचोटि तपाईँलाई जाँच गरेर हेर्छु है एकचोटि यो स्वेटर खोलिदिनुहोस् त कपाल पनि यसो अगाडि राखिदिनुहोस् म तपाईँ पहिला सुट टाउको है तपाईँले अघि के भन्नुभएको थियो टाउको अगाडि झुक्दाखेरि दुख्छ भन्नुभएको थियो ल यसो अहिले दुख्या छ कहाँ दुख्या छ एकचोटि देखाउनुहोस् त यही एरियामा हो दुख्ने यता एरिया अब मैले यसो गर्दाखेरि दुख्या छ यसो गर्दा दुख्या छैन मैले यसो गर्दाखेरि दुख्या छ कहाँनिर दुख्या छ यता ओके यसो गर्दाखेरि दुख्या छ कहाँनिर ओके सो तपाईँले टाउको अगाडि गर्दाखेरि दुख्यो पछाडि गर्दाखेरि दुख्यो र साइड साइड गरेर दुख्यो होइन म टाउको अलिक थिचेर म यसो घुमाउँछु यो दुख्या छ छैन छैन यो गर्दाखेरि दुखेको छैन होइन So I'm checking range of motion. She has pain during flexion of neck and lateral bending of the neck. But when the neck is extended, there is no pain. And also rotation of head is also there is no pain. Okay. Now I'm going to see the palpate the muscle. So she is telling that this area is painful. So I'm basically palpating the joint, muscles and ligament in that area. Okay. मैले यहाँ थिच्दाखेरि दुखेको छ छैन मैले यहाँ थिच्दा दुखेको छ So just now I have palpated the upper facet, cervical facet and lower cervical facet. There is no tenderness. So now I am going to palpate the muscle which she is saying is painful. So मैले यहाँ दुखेको छ दुखेको छ दुख्यो यही हो तपाईलाई दुख्ने यहाँ पनि दुखेको छ दुखेको छ यहाँ माथि छैन So मेन दुख्ने नै यही हो हैन मैले यहाँ थिच्दाखेरि दुखेको छ So I'm palpating the occipital area. Sometimes there can be occipital neuralgia, which is known as cervicogenic headache. So यहाँ दुखेको यो टाउको दुखेको आएको छैन नि तर यो चाहिँ दुख्छ So bilateral trapezius is tender. Okay. So bilateral trapezius is tender. She says that the radiation of pain is to the head. There is no radiation of pain to the arm, but still I am checking the Sperling test and relief sign and other neurological examination of the hand to rule out any cervical disc prolapse and cervical pathology. म तपाईको टाउको यसरी थिच्छु थिचेर म जबरजस्ती यो टाउको यसो गरिदिन्छु त्यो बेलामा दुख्छ कि दुख्दैन हेरौँ है त सो पहिला नथिचिकन यसो गरेर हेर्छु तपाईँ दुख्छ कि दुख्दैन भन्ने है त सो आई एम बेसिकली चेकिङ द stretching the trapezius muscle to see whether there is tenderness or not. मैले यसो गर्दा दुखेको छ कहाँनिर दुखेको छ So there is tenderness on the ipsilateral side of the trapezius. So यसो गर्दा दुखेको छ कहाँनिर दुखेको छ So here the ipsilateral bilateral trapezius stretching is positive. Now I am checking the Sperling sign which is mainly for the cervical radiculopathy. So मैले यहाँ थिच्छु र जबरजस्ती यो टाउको म लेफ्ट साइडतिर लाँदैछु यो लाँदाखेरि तपाईलाई हाततिर झमझम आएको त्यस्तो केही छ छैन हैन So there is no radiation of pain in hand while doing left side is swirling. Now I am checking the right side is swirling. यसो गर्दाखेरि तपाईको हाततिर झमझम आएको छ छैन तर यहाँ दुखेको छ कि छैन यो ठाउँमा So she is only having pain in the trapezius in the contralateral side but in ipsilateral hand there is no radiation. Okay. So यो भयो यो हल्के पनि अप्ठ्यारो छैन है अहिले यो त दुखेकै छ हैन अब म एकचोटि हातले एकचोटि चेक गर्छु So basically मैले यहाँ छोएको यो छोएको बराबर छ यो चाल बराबर छ हातलाई एकचोटि यसो गर्नुस् त आफूतिर तान्नुस् त यो अप्ठ्यारो छ छैन यसलाई सिधा गर्नुस् त सिधा यसो ठेलेर सिधा गर्नुस् त ओके ठिक छ यो यसलाई यसो श्रग गरेर माथि लानुस् त फर्स्ट क्लास यो हातलाई यसो माथि लानुस् त माथि यसरी माथि लानु ठिक छ माथि लानुस् ठिक छ तल लानुस् ठिक छ यो पनि तल लानुस् ठिक छ सो म एकचोटि करेन्ट जस्तो लाग्छ कि लाग्दैन करेन्ट जस्तो लाग्यो यसमा थाहा पाएन होइन झस्सँग झट्का आएको सो मेरो विचारमा त बहिनी यो चाहिँ यसलाई चाहिँ टेक्निक प्रब्लम भन्छ यो चाहिँ अहिले चाहिँ एकदमै ठुलो समस्या लिएर आउँदैछ यो अहिले किनभने अहिले हामी बच्चा जन्मिँदैछनै मोबाइल दिन्छौँ र अहिले चाहिँ अब बेसिकली चाहिँ हाम्रो धेरै जस्तो डेली कामै मोबाइल ल्यापटप र डेस्कटपहरूमा हुन्छ र स्पेसली अहिले के भन्छ हामीलाई भगवान्ले चाहिँ सिधा बसेर बनाएको जस्तै कान चाहिँ हाम्रो यो सोल्डरको लेभलमा हुनु पर्यो तर अहिले टेक्नोलोजीको विकास भएसँगै अब हामीले चाहिँ धेरै जस्तो हामी ल्यापटप युज गर्न थाल्छौँ मोबाइल हेर्न थाल्छौँ यसरी फेसबुक टिकटकहरू होइन युट्युबहरू र हाम्रो डेली अफिस काममा पनि तपाईँको टाउको झुकाएरै गर्नुपर्छ र त्यो धेरै टाउको झुकायो भने यो पछाडिको टाउको मासुहरू बिसाउँछ स्ट्रेन हुन्छ त्यसलाई चाहिँ एकदम नेक प्रब्लम भन्छ भनेको मतलब टेक्नोलोजीले गरेर नेक प्रब्लम हो र मेरो विचारमा तपाईँलाई पनि त्यही समस्या छ तपाईँको यो घाँटीमा नसा च्यापेको होइन धेरै जस्तो छ सो यो माइग्रेन पनि होइन, किनभने कहिलेकाहीँ चाहिँ यो सानो सानो नसाहरू घाँटीबाट तपाईँको टाउकोमा चाहिँ तपाईँको यो नसाहरू चाहिँ माथि जान्छ। जस्तै तपाईँलाई अहिले टाउको दुख्यो र तपाईँले चाहिँ यो माइग्रेन हो किन भन्ने शङ्का आउनु चाहिँ स्वाभाविक हो। सो जहिले पनि टाउको दुख्न साथै माइग्रेन नै हुन्छ भन्ने छैन, कहिलेकाहीँ घाँटीको कारणले पनि टाउको दुख्छ। र अहिले जुन चाहिँ यो तपाईँलाई घाँटी दुख्ने र सँगै टाउको दुख्ने चाहिँ यो नर्मली चाहिँ यो टेक्निक प्रब्लमसँगै सम्बन्धित हुन्छ। जब पछाडिको घाँटीको मासुहरू रिसाउँछ तब टाउकोमा जाने सानो नसाहरू चाहिँ च्यापिन्छ र त्यसपछि यसले दुखाउँछ। र नर्मली माइग्रेन हुँदाखेरि चाहिँ तपाईँलाई चाहिँ यो चाहिँ अब वाकर लाग्ने, लाइटहरू हेर्न नसक्ने यिनीहरू हुन्छ र फ्यामिली हिस्ट्री पोजिटिभ हुन्छ। जस्तो तपाईँको दिदीहरू आमाहरूको पनि यो माइग्रेनहरू सक्छ। मेरो विचारमा माइग्रेन होइन। र अर्को चाहिँ बाथ हुन सक्ने पनि पोसिबिलिटी छ। र बाथमा चाहिँ धेरै जस्तो दुखाइ चाहिँ घाँटीको दुखाइ चाहिँ बिहान र पख हुन्छ। तर तपाईँलाई त बिहान पख त तपाईँलाई एकदमै आराम छ। तपाईँलाई मेन दुख्ने चाहिँ टाउको झुकाएर काम गर्दाखेरि भयो। सो यो भनेको यो चाहिँ हाम्रो नर्मल टाउकोको वेट चाहिँ 5 किलो हुन्छ अरे। जब हामी यो टाउको झुकाउँछौँ तब टाउकोको वेट बढेर 5बाट 12, 12बाट 16, 16बाट झन्डै 30 किलोसम्म हुन्छ। र 30 किलोको यो टाउकोलाई यो मासुले पछाडि तान्न चाहिँ गाह्रो हुन्छ। र लामो समयसम्म तान्यो भने यो रिसाउँछ र त्यसलाई चाहिँ टेक्निक प्रब्लम भन्छ है त। म तपाईँलाई यसो देखाउँछु है त कम्प्युटरमा एकचोटि। समस्या चाहिँ यो हो। सो यसलाई चाहिँ तपाईँले चाहिँ एक तपाईँले पनि गुगलमा हेर्न मिल्छ। यो मैले सबै यो गुगलबाटै देखाएको हो हजुरलाई। सो तपाईँको कस्तो हुन्छ भने जस्तै मैले यो फोटो देखाएँ तपाईँलाई, हेर्नुहोस् त। तपाईँले यदि यो फोटो हेर्नुभयो भने होइन, यसमा तपाईँले देख्नुभयो भने यो रोगको नामै छ। यसलाई चाहिँ अर्को नाम चाहिँ टेक्स्ट नेक पनि भन्छ, धेरै पढ्नेहरूलाई पनि हुन्छ यो होइन। सो बेसिकली के भयो हेर्नु त, यो धेरै तपाईँले यो फोटो तपाईँले हेर्नुभयो भने धेरै टाउको झुकाएर ल्यापटप डेस्कटपमा काम गर्नुभयो, मेनली त ल्यापटपमा या मोबाइलहरू चलाउनु भयो भने यो नेक प्रब्लम हुन्छ। यसलाई नै टेक नेक प्रब्लम भनेको हुन्छ। र अहिले तपाईँले यदि यो हेर्नुभयो भने हेर्नु त, हामीलाई भगवान्ले यसरी सिधा बस्नु बनाएको हो। यो सिधा बस्दाखेरि टाउको तौल 12 पाउन्ड या 5 किलो छ भने जति हामीले टाउको अगाडि झुकाउँछौँ त्यति टाउको तौल बढ्दै जान्छ। जस्तै यो रातो 60 डिग्री, 60 डिग्रीमा टाउको झुकायो भने हाम्रो टाउको तौल हेर्नु त 12 पाउन्डबाट 60 पाउन्ड भन्ने चाहिँ झन्डै 30 किलो हुन्छ। र यो हुँदाखेरि पछाडि जुन चाहिँ मासुले पछाडि तान्ने मासु चाहिँ रिसाएर बस्छ। र त्यो चाहिँ लामो समयसम्म कम्प्युटरमा काम गर्ने मान्छे, स्पेसली कम्प्युटर भन्दा नि ल्यापटपमा या मोबाइल धेरै चलाउने मान्छेहरूलाई चाहिँ यो मासु रिसाएर बस्छ। र तपाईँको अहिले मासु रिसाइरहेको मासु चाहिँ यो हेर्नुहोस् है, ट्रापेजियस मसल भन्नुहुन्छ। यो तपाईँको ट्रापेजियस मसल भनेको चाहिँ यो मासु हो। यसले चाहिँ के गर्छ त, तपाईँको यो मासु होइन, यो मासुले तपाईँको हेर्नु टाउको तलसम्म जान्छ। र जति यो टाउको तल झुकायो यो दुइटै मासु रिसाएर बस्छ। र यो मासु रिसाउँदाखेरि पनि घाँटी दुख्ने र टाउको दुख्ने हुन्छ। सो तपाईँलाई यो टाउको दुखेको चाहिँ माइग्रेनले होइन, यसलाई चाहिँ सर्भाइकोजेनिक हेडेक भन्छ। भनेको मतलब घाँटीको कारणले, घाँटीको मासु रिसाएको कारणले गरेर तपाईँको टाउको दुख्या हो। र यो दुख्दाखेरि म अझै एउटा फोटो देखाउँछु है तपाईँलाई। मसल स्पाजम जस्तै यो भयो हेर्नु त, तपाईँलाई दुख्ने चाहिँ यस्तै छ ठ्याक्कै यो टाउको दुख्ने गर्छ। जस्तै यो होइन, यसरी नै दुख्छ हो। ओके, सो अहिले मैले छाम्दाखेरि यो दुइटै मासु रिसाएर बसिरहेछ। र यो मासु रिसाउँदाखेरि कहिलेकाहीँ यो टाउको फेदसम्म जान्छ, जुन चाहिँ तपाईँले अहिले टाउको दुख्यो भन्नुभएको यो भयो। र कहिलेकाहीँ यो टाउको दुखेको सरेको हेर्नु त, यो टाउको यो कन्चरसम्म या अहिले आँखासम्म या यो जसम्म पनि आउँछ। सो समस्या यहाँ होइन, टाउकोमा होइन या माइग्रेन होइन, समस्या चाहिँ यहाँ घाँटीको मासु रिसाएको। र त्यो मासु रिसाएर त्यसको तोड चाहिँ तपाईँको टाउकोसम्म आएको। र यसलाई चाहिँ टेक्निक प्रब्लम भन्छ। र बेसिकली अब उपचार कसरी गर्छौँ भन्दाखेरि मेन कुरा चाहिँ के कारणले तपाईँलाई यो समस्या भएको छ त्यो कारण कम गर्नु पर्यो। भनेको मतलब यो चाहिँ टेक्नोलोजीले गरेर नेक पेन भएको हो। र तपाईँले चाहिँ अघि मैले भनेको चाहिँ तपाईँले चाहिँ पहिला चाहिँ डेस्कटप चलाउनु हुन्थ्यो र अहिलेको नयाँ काममा तपाईँ ल्यापटप चलाइराख्नु भएको छ। सो वान अफ द यो मेन कल्प्रिट चाहिँ यो चाहिँ ल्यापटप हो। जस्तै ल्यापटप चलाउँदै हाम्रो टाउको यस्तो हुन्छ र घाँटीमा स्ट्रेन धेरै हुन्छ। तर त्यही कुरा हामीले डेस्कटप चलाउँदै आँखाको लेभलमा हुन्छ र स्ट्रेन हुँदैन। सो यो इजी हुन्छ। सो मेरो विचारमा हामीले उपचार गर्दै पहिला चाहिँ हामीले लाइफस्टाइल चेन्ज गर्ने। लाइफस्टाइल चेन्ज गर्ने भन्नाले के भन्नु त, अब अफिसमा चाहिँ तपाईँले के रिक्वेस्ट गर्नु पर्यो त, मेरो चाहिँ यो ल्यापटप धेरै चलाएर घाँटी दुख्न थालेछ र टाउको दुख्न थालेछ, मलाई चाहिँ प्लिज ल्यापटपमा सट्टा मिल्छ भने चाहिँ मलाई डेस्कटप राखिदिनु। डेस्कटप डक्टरले चाहिँ डेस्कटपमा राखेर पोजिसन चेन्ज गर्यो भने चाहिँ यो समस्या सल्भ हुन्छ भनेर छ भने सो तपाईँले ल्यापटपलाई चेन्ज गरेर डेस्कटपमा राख्ने 2 नम्बर चाहिँ मोबाइलको स्क्रिन टाइम लिमिट गर्ने भनेको मतलब तपाईँले मोबाइल त सबैले चलाउनै पर्यो जस्तै मोबाइल त अब आजकल त मोबाइल त अनिवार्य नेसेसरी छ त्यो हामीले यसरी मोबाइल चलाउनु भएन मोबाइल चलाउनु पर्यो भने अलिकति स्क्रिन माथि राखेर यसरी चलाउने ताकि आँखाको लेभलमा होस् यसरी चलाउने चाहिँ होइन है सो यसरी चलाउने र सकेसम्म यो स्क्रिन टाइम चाहिँ लिमिट गर्ने 2 नम्बर होइन 3 नम्बरमा चाहिँ के गर्ने यो मासु जुन रिसा छ त्यसलाई स्ट्रेच गर्ने एक्सर्साइज गर्छ म तपाईँलाई त्यो एक्सर्साइज सिकाइदिन्छु र त्यो एक्सर्साइज चाहिँ एटलिस्ट बिहान बेलुकी रेगुलरली गर्ने है र अहिलेको 2-3 हप्ता चाहिँ त्यो एक्सर्साइज गर्नुभन्दा अगाडि अलिकति दुखाइ कम हुने मलम लाउने तातोले सेक्ने यता र यता दुवै ठाउँमा किन तपाईँको दुवै ठाउँमा दुखिरहेछ तातोले सेक्ने र सेकेको 2-4 मिनटपछि जति सेकेपछि अनि म तपाईँलाई जुन सजिलो एक्सर्साइज छ त्यो एक्सर्साइज चाहिँ 5 मिनट जति बिहान बेलुकी गर्ने है त कुन एक्सर्साइज भन्दा हेर्नुहोस् है यो मेन त यो मासु रिसा हो नि त तपाईँको त्यसपछि यो हातले यहाँ पुच्छेमा समात्ने र यो मासु स्ट्रेच गर्न चाहिँ टाउको यसरी राख्ने यो मासु चाहिँ तपाईँको तन्किन्छ तपाईँ हो मसँग गर्नु हो यसरी यसरी 10 सेकेन्ड यसरी तन्काउने र 10 सेकेन्ड रिल्याक्स भएर बस्ने होइन र फेरि यसरी 10 सेकेन्ड तन्काउने हेर्नु त मैले हात यसरी समातिरहेको छु अर्को हात यसरी राख्न पनि मिल्छ यो हात हेर्नु त हो यसरी राखेर यसरी पनि स्ट्रेच गर्नु मिल्छ यसलाई चाहिँ ट्रपिजियस स्ट्रेच एक्सर्साइज भन्छ यसले चाहिँ यो रिसाको मासु चाहिँ रिल्याक्स गरिन्छ र यता सँगै तपाईँ यता पनि रिसान्छ र सेम कुरा यसरी 10 सेकेन्ड स्ट्रेच गर्ने 10 सेकेन्ड आरामसँग बस्ने 10 सेकेन्ड स्ट्रेच गर्ने 10 सेकेन्ड आराम गर्ने यो एउटा एक्सर्साइज भयो यो 5 चोटि यता 5 चोटि यता 5 चोटि गर्ने र 2 नम्बरको एक्सर्साइज चाहिँ चिन टक एक्सर्साइज भन्ने छ चिन टक नामैले बताउँछ चिनलाई टक गर्ने यसो गर्ने यसरी हात राख्ने होइन अब के गर्ने त यसलाई चाहिँ पछाडि लाने यसरी हो यसरी होल्ड गर्ने 5 सेकेन्ड होल्ड गर्ने फेरि यसरी आउने 5 सेकेन्ड रेस्ट गर्ने फेरि 5 सेकेन्ड होल्ड गर्ने यसलाई चाहिँ चिन टक भन्छ यो दुईटा एक्सर्साइज चाहिँ तपाईँले चाहिँ रेगुलरली गर्नु पर्यो अफिसमा चाहिँ तपाईँको लाइफस्टाइल अलि चेन्ज गर्नुहोस् सकेसम्म डेस्कटपमा चेन्ज गर्नुहोस् होइन र अरू गर्न सक्ने चाहिँ अहिले म तपाईँलाई चाहिँ दुखाइ कम हुने औषधि दिन्छु केही दिनलाई 5-10 दिनलाई र मसल रिल्याक्सन दिन्छु मसल पनि रिल्याक्स होस् यसले तपाईँको घाँटीको दुखाइ पनि कम हुन्छ र टाउको दुखाइ पनि कम हुन्छ तर सधैँ यो दुखाइ कम हुने औषधि खाएर सधैँ यो मसल रिल्याक्सन खाएर त बस्नु भएन त्यो भएर मेरो सजेसन चाहिँ हजुरलाई चाहिँ प्लिज तपाईँले चाहिँ आफ्नो लाइफस्टाइल चेन्ज गर्नै पर्छ र टाउको धेरै झुकाएर हेर्नु हुँदैन है र अर्को कुरा चाहिँ यदि तपाईँलाई स्विमिङहरू मनपर्छ या एक्सर्साइजहरू मनपर्छ भने जगिङ जगिङ र स्विमिङ पनि राम्रो एक्सर्साइज हो यसले चाहिँ यो नेकको पछाडिको मसलहरूलाई बिल्डअप गर्छ र तपाईँ त अब रिसेप्सन काम हो सधैँ यसरी नै बस्नुपर्छ र त्यसले त अब तपाईँले जागिरै छोड्ने त कुरा आएन सो तपाईँले चाहिँ एटलिस्ट लाइफस्टाइल चेन्ज गर्ने एउटा कुनै एक्सर्साइज लाइक वकिङ जगिङ या स्विमिङ चाहिँ आफ्नो लाइफस्टाइलमा हाल्ने त्यो गर्नुभयो भने ठिक हुन्छ र मानिलिउँ सपोज अब यो औषधि खाएर पनि तपाईँलाई कम भएन या तपाईँले अब डेस्कटपमा चेन्ज गरेर पनि यो समस्या भइराख्यो भने चाहिँ या यो समस्याले तपाईँलाई छोडेन भने चाहिँ हामीले के गर्न सक्छौँ भने यो जुन चाहिँ रिसाको मासुलाई चाहिँ हामीले ट्रिगर पोइन्ट इन्जेक्सन भन्छ त्यो मासुलाई चाहिँ अकुपङ्चर गरे जस्तै गरेर मल्टिपल चोटि घोटेर त्यसलाई रिल्याक्स गर्न सक्छौँ त्यो चाहिँ हाम्रो प्लान बीमा मात्र छ होइन फर्स्टमै सुई त कसैले लाउँदैन र सुई लाउने यसको उपचार पनि होइन तर मेन त तपाईँले लाइफस्टाइल चेन्ज गर्ने औषधि खाने र मैले जुन चाहिँ चिन टक र यो ट्रपिजियस स्ट्रेच एक्सर्साइज भने त्यो एक्सर्साइज चाहिँ तपाईँले रेगुलरली गर्नुपर्छ यति गरे पनि ठिक हुन्छ है र इन्जेक्सनको प्रविधि भनेको यो यदि यो मुखले खाने औषधि र तपाईँले फिजियोथेरापी र लाइफस्टाइलले चेन्ज भएन भने चाहिँ यता हेर्नुहोस् त त्यसलाई चाहिँ हामीले ट्रिगर पोइन्ट इन्जेक्सन भन्छौँ ट्रिगर पोइन्ट यो भनेको के हो भन्दाखेरि यसरी तपाईँको मासु रिसाको मासुलाई चाहिँ यसरी यो रिसाको मासुलाई हामीले 10-15 चोटि यसरी बोलिदिन्छौँ त्यसले चाहिँ यो रिल्याक्स हुन्छ यो पनि गर्न सक्छ तर यो हामी प्लान बीमा मात्र राख्दैछौँ प्लान एमा राख्ने होइन यसरी यो मान्छेलाई कति ठाउँमा दुख्यो होला त है तपाईँलाई गर्ने चाहिँ यो दुईटा मात्र हो यिनीहरू होइन जहाँ जहाँ दुख्यो त्यसमा चाहिँ हामीले यसरी ट्रिगर पोइन्ट इन्जेक्सन भन्ने गर्न सक्छौँ यसरी हेर्नु त यो ट्रिगर पोइन्ट यो धेरैजना मान्छेलाई दुख्छ यसरी र हामीले चाहिँ यदि औषधिले भएन भने चाहिँ यसरी हामी यो ट्रिगर पोइन्ट इन्जेक्सन भन्ने लाउँछौँ तपाईँले त्यो बारे अलिकति पनि हेर्नु होला तर मेन चाहिँ ओरल मेडिसिन फिजियोथेरापी exercise र लाइफस्टाइल चेन्ज ओके सो तपाईँले घरमा गएर यो टेक्निक प्रब्लमको बारे हेर्नुहोस् र अफिसमा चाहिँ तपाईँ लाइफस्टाइल चेन्ज गर्नुहोस् ओके वरि नगर्नुहोस् म औषधिहरू लेखिदिन्छु र ठुलो विकराल समस्या जस्तो लाग्दैन तर तपाईँले टेक केयर चाहिँ गर्नुपर्छ ओके थ्याङ्क यू
So recently, this is the case regarding the technique problem. I'm sure everybody would want to read about this. Okay, I have prepared a PowerPoint presentation regarding this. I think it's very interesting. Okay, can you see the slide?
Yes, it is.
Excuse. Yes.
Yes,
Okay.
yes.
So let's discuss something about technique problem. I think it's new for. We know that muscle strains are there, but let us discuss this in detail regarding technique problem. Okay. So the patient regarding the summary of the patient. The patient was 25 years old female who used to work as a receptionist and account, and she came to my clinic on just this Thursday with neck pain for 2 months. So she works as an accountant as a job description, and she told me that there was a gradual onset of neck pain since last 2 months. It was deep aching in nature, and numerical rating scale was maximum 7 and minimum it was 2 to 3. Occasionally pain radiated to head, but it not did not radiate to arm or the forearm. The pain was aggravated by neck flexion, as well as while working with computer. Especially she's using laptop nowadays. So pain relief was there with rest, non-steroidal anti-inflammatory drug, heat, as well as massage, and there was no history of morning stiffness, no history of inflammatory arthropathy in family, and there was also no history of migraine in that patient. Okay, so on examination what we found out was, on range of motion examination, there was discomfort during forward flexion and lateral bending of the neck. Okay, and rotation of the neck was not painful, and during palpation upper and lower facets joints were not tender. Bilateral trapezius joint was trapezius muscle was tender, and trapezius stretch test was positive, spurling test was negative, relief sign was negative, and other neurological examination was also negative. So my diagnosis was neck problem, especially due to myofascial pain, trapezius muscle spasm bilaterally, and we have planned for conservative management in this patient. I've started with aceclofenac 100 mg 2 times a day for 10 days after food, and I've also started capsule thiacolchicoside, which is a muscle relaxant, 4 milligram 2 times a day for 10 days. And along with the medication, I have advised her to do lifestyle changes such as limit the screen time, change laptop to desktop, and I've also advised her to go for like exercise like jogging, swimming, and other activity. So, and also advise her to go for trapezius stretch exercise and chin tuck exercises regularly, as she has to work in the computer. That is her job description. So, and as well as apply non-steroidal anti-inflammatory ointment and heat in every morning and night, at least for few weeks, initial few weeks. And we have planned, if the conservative management fails, or if it's inadequate, we are planning to go for trapezius trigger point injection in that patient. Okay, with this history, let us discuss the case. So this neck problem is also known as text neck problem, and it is usually caused by repetitive strain or injury to the muscle and other tissue structure which is near to the neck or cervical spine. So main thing is that with evolvement of science and technology, mainly technology, we are much more hooked to laptop, tablet, and smartphone nowadays, and we now flex our neck for a prolonged period of time. And it is estimated that there has been various studies regarding this, and it is estimated that in an average a person spends around 4 hours a day flexing the neck. So it includes from the morning to night. So they have done the study. They say that 4 hours of our daytime we are bending our neck in a forward flexion, and this is the main cause or culprit for repetitive strain in the neck and upper back, and it has almost become nowadays epidemic, and more patient with tech neck or text neck problem are coming to pain clinic. So I basically encounter every week more and more patient with tech neck or text neck nowadays. So that's why I wanted to present this case. Okay, so this is the I'm sure this is the typical scenario in every household. So in this we started as the chimpanzees, and our evolution started as a human being, but after the introduction of smartphone and tablet, now look how we are dependent upon that smartphone and tablet nowadays. And if you walk by a mall, or if you go to the class, or anywhere you go, like anywhere in as well as in home, you will find 6 or 8 out of people using tablet, smartphone, laptop like this. Okay, and I'm sure this is also in the right side picture. This is also typical picture of our children nowadays, hooked up to the smartphone, laptops nowadays, and bending our head forward. So this has become nowadays endemic, and growly, if we don't advise or educate people, especially the young kids and adolescent people, as well as the elderly population, to take off screen time and use various precaution that we'll be talking in later slide, this can be a very much problematic nowadays in our society. Okay, so regarding epidemiology, there has been studies. A recent study in 2023 has estimated that like total number of global smartphone user will reach up to 6.8 billion, but our global population is just 8 billion. So it is it's very dangerous. So nowadays 8 out of 10 people is said to be equipped with smartphone. That is about 85% of the world population will be hooked to the smartphone and tablet and laptop. Okay, so and there is also recent studies figures which has shown that 87% of the teenagers between 14 to 18 years in USA, and 79% of the teenagers between the age of 12 to 15 years in UK own or use smartphone. I'm sure the ratio is not as big as 87%, but in Nepal also, as well as India also, most 60% or more teenager, or 70% or more teenager are hooked up to the smartphone and the tablets and the laptop. So among adult population between 18 to 34, 92 to 95% reported having a smartphone in USA or in Australia respectively. So this is the epidemiological data of the recent data, which shows a very dangerous condition, leading to most of the people will have a technique problem once in their lifetime. Okay, so here in technique problem there are lots of multiple pain generators, especially the muscles, ligament of the neck, especially the trapezius, posterior part of the neck, levator scapulae, splenius cervicis, capitis, erector muscle, and other sternocleidomastoid muscle are the main muscle which can get weak after prolonged flexion of the neck. And these weakness of the muscle can also cause occipital nerve entrapment, mainly the greater and third occipital nerve entrapment, causing headaches. There can be cervical facet joint problem in these group of population. Cervical disc generation is gradually like increasing in nowadays in our population. Cervical disc prolapses are also common in these people if it's chronic. And in chronic cases, early onset of osteoarthritis, permanent deformity like kyphosis or loss of lung capacity has also been reported in these group of population. Okay, so these are the all problems that can occur, and these are the pain generators that can happen in those patients who are having a technique problem. So if you come see the mechanism of technique problem as shown in the picture, so basically our human body is designed to see straight. Okay, so our ears should be just above our shoulder joint. This is how we should be standing most of the time. But and in this condition our weight of the head is usually about 12 pound or 5 kg. But as you can see in this picture, if we flex our head 15 degree, the relative weight of the head becomes 12 kg. So if we flex our neck to 30 degree while using smartphone or laptop, then our relative weight of the head will become 18 kilo. Similarly, in 40 45-degree flexion, our weight of the head will be 22 kilo. And finally, in 60-degree flexion, our weight of the head will be relatively 27 kilo. So see the gradual increase in weight. From 5 kilo, it can be up to the maximum of 30 kilo. So when we use smartphone and laptop for a prolonged period of time during flexion, then the muscle of the back can get strained and there can be weakness of the muscle. So this is the main culprit for the technique problem. So our neck is basically simply not built to withstand this pressure. Okay. And when we chronically flex our neck, this results in muscular and ligamental strain and other facetal and other disc issue that we have described in the previous slide. And it is said that an average cervical spine angle flexion while we are doing SMS or texting is about 37 degree to 47 degree. So this is a normal average flexion of our cervical spine while texting or using smartphone. And studies has also shown that basically the weight of the head increases from 5 kilo to 18 to even 30 kilo. Okay. At 18 kilo at 30-degree flexion and 22 kilos at 45-degree flexion. So if you see the angle of flexion, so while texting our angle of flexion is 37 to 47 degree. So imagine how heavy our head will be. So 30-degree flexion, our head weight will be 18 kilo, and 45-degree flexion, our weight will be 22 kilo. So this can lead to inflammation of the ligaments of the back of the neck, muscle and nerve strain in the back of the neck, and it can even lead to like permanent damage, arthritic damage of the neck, and even causes like kyphosis, deformity in the later part of the life. Okay. So regarding the symptom, so these group of people will usually come with sharp or nagging pain in the back or in the shoulder. They can also cause stiffness or tightness in the shoulder and neck, basically leading to decreased range of motion. And they can also have increased pain when tilting your head forward while texting. Okay, like while texting we usually do this flexion, so there can be pain during flexion of the neck. And these group of patients also can have intermittent or constant headaches. This is basically a cervicogenic headache. And you may have noticed in this patient, she was also worried about migraine because she was having a headache after the neck pain. So headaches are very much common nowadays with text neck problem. And there can be occasional nerve pain with tingling and numbness to the upper limb due to the irritation of the cervical spinal nerve. And jaw pain and eye pain can also be expected in this group of population. So regarding the percentage wise, you can see here, so 60% of patients basically experience health problem due to this technique problem or due to the prolonged use of laptop and desktop, or especially the smartphone. And they can have 24% of the people can have headache. Even look, 36 population of has been reported to have eye strain. Neck pain is very much common. Back pain is also 30% they have reported. Upper back 12% and lower back even 24%. Wrist pain are also there because of use of mobile. Carpal tunnel syndrome or even the cubital tunnel syndrome can also happen if you are using too much of smartphone. And insomnia has also been reported, and other cases are also has been reported. So these are all the symptoms of the text neck problem. So during evaluation of patient with this technique problem, complete medical history has to be taken. And we should also take history regarding the uses of electronic devices, how long they have been using, what are the electronic devices the patient is using, and what is the position of the patient while using this electronic device. This history has to be elicited during the history taking. And we also should ask about onset of symptom, how the symptom is getting relieved. And regarding the examination, we are basically seeing there can be visible deformity in chronic patient with technique problem. Range of neck should be evaluated. We should palpate all the bones, joints, and the muscle of the neck during evaluation. And complete neurological examination of upper limb is mandatory, including cervical nerve entrapment. As we have seen in the patient, we also did the cervical nerve impingement test or radicular pain test in this patient. So this should not be missed in those patients. So this is the X-ray of C-spine with AP and lateral view. Actually, this is an extreme X-ray. So this is not expected in for a. This can be a chronic technique problem patient x-ray can be a this x-ray of that, but I just wanted to add you the severity of the cervical spine deformity in chronic case of technique problem. So here you can see S-shaped deformity and the cervical spine, which is corrected after 9 months of physiotherapy. So after 9 months of physiotherapy, this is the post physiotherapy x-ray is this, but this is the x-ray pre-treatment x-ray is this before physiotherapy in the patient with technique problem. Okay. So regarding the management of the patient, here the main goal is prevention. As we all know, prevention is better than cure. So first thing is to avoid excessive use of smartphone and other handheld devices, including laptop and tablets, has to be avoided. And we should take a frequent break if you are used to or if our job demands using this laptop, tablet, or smartphone, then we should advise the patient to take frequent break in between. So we can use alarm. So he or she can use alarm in every 45 minutes to 1 hour. If the alarm rings out, so he or she can stand up and walk around and do some neck flexing exercises to prevent this technique problem. So we should also avoid prolonged static position, especially in the chair. If you stay prolonged, especially IT workers, accountant, even the doctors, we tend to stay in a chair for a prolonged period of time. This can also cause technique problem and back pain in majority of cases. Okay, so we should always also advise patient to position the device in such a way that it reduces the stress both in head and neck and upper extremities. As you have noticed in that patient, I advise her to change the laptop to desktop. Okay, so this is one of the modality. While using laptop, our head tends to flex a lot. So if we use desktop, and that too in a proper manner, we can avoid this technique problem to much extent. Okay, and we can also use smartphone. We instead of flexing our head too much, we can put our smartphone above to our angle of the eye, okay, to at the level of the eye. So this can also prevent repetitive stress in the back of the neck. And we also have to tell the patient to avoid high repetitive motion of the neck, such as prolonged typing. So these things has to be avoided. Okay, and we can also tell patient to do regular physiotherapy to strengthen the neck muscle, especially the back muscle. And they can also join swimming, jogging, walking. So these activity usually basically builds up the muscle of the back. So these activity are very good. So I am very fond of swimming, so I also have to spend a lot of time in doing like laptop work or texting. So swimming is a good way of therapy for me, and I advise everybody to use some kind of physical activity and physiotherapy. Nowadays we are all whether we like it or not, we are using these smartphone, tablets, and various handheld devices. So be very cautious about this problem. It can happen to all of us. Okay, so these are the precautions that we should advise to the patient. Okay, so avoid prolonged use of smartphone, laptop, and handheld device. Use of alarm system. If our job demands using prolonged laptop or texting, then we can use alarm, and in every 45 minutes and 1 hour we can get alarm and then do repeated stretching of the neck exercises. And here you can see, okay, so we have to you have to change the position of the laptop or desktop. Here you may have noticed the patient is using laptop, and his neck is flexed too much. Okay, here what they can do is they can elevate the height of the laptop, or they can use desktop so that the screen is at the level of the eye. So this can also avoid text neck problem. Here also, while using smartphone, this is the wrong position. Female is bending her neck too much, so this can give rise to text neck problem or headache, or there can be various complication associated. So smartphone are essential. We cannot live without smartphone, okay, nowadays. So while using smartphone, if you use the smartphone for a long time, and if you use at the level of eye, that would be a good posture to use smartphone. And these exercises, especially the trapezius stretch exercises or chin tuck exercises, can be done during day hours or our office hours to prevent the neck problem. And we can also advise patient to go for jogging, walking, swimming, or the cycling. So these are very good exercises which can build up the neck muscle at the back. So these preventive measures has to be advised to the patient. Okay, so but in acute cases, basically we usually start with medication like we did in this patient. Like we started with non-steroidal anti-inflammatory drug because trapezius was too much painful. We can also use muscle relaxant for 1 week or 2 week or even 2-3 weeks of muscle relaxant can be used. The good choice of muscle relaxant is thiazide, or we can also use baclofen, which is very much common nowadays. We can use ice or heat packs in the trapezius or other neck muscle which is causing problem. We can tell the patient to do regular neck movement like rotation and side bending of the neck while taking frequent break. We can also tell the patient to advise the patient to go to physiotherapy. I usually the common physiotherapy I usually tell the patient, but it is advised to send the because pain management is a multimodal therapy. So so physiotherapists are there who will give the patient better exercises, and who will be knowing better exercises than us. So we have to refer to the patient to the physiotherapist so that they can build up the muscle in the back. So the good exercise is what that I found and I do regularly is trapezius stretch exercise and chin tuck exercise. Massage is also very good in these conditions. So these are all done in acute cases and subacute cases. But in chronic cases, yes, we start with NSAID and muscle relaxant, but we might have to go for injection like trigger point injection, whatever is giving the problem. So the target point is, suppose if the trapezius or other muscle is causing problem in the neck, we can go for trigger point injection, or we can go for spinal accessory and dorsal scapular nerve block, which will take care of trapezius, sternocleidomastoid, levator scapulae, and rhomboid. So if the multiple muscles are involved, we can go for SASD block, which we commonly do in Daradia, the pain clinic. Or if single muscle is involved, such as trapezius or sternocleidomastoid or levator scapulae, in those conditions, we can only go for a single trigger point injection after palpation. If the facet is going causing problem, we can give facet joint injection. We can also go for epidural steroid injection if trigger point injection and facet joint injection are not helping. And we can also go for nerve block if the spinal nerve is getting irritated. Like in previous patient, we can use ultrasound guided selective cervical nerve block, or or spinal accessory or dorsal scapular nerve block can be given to that patient. And physiotherapy is one of the vital key. So we have to send the patient for physiotherapy for progressive resistance exercise, as well as which will improve the muscle strength. Okay, so thank you very much. So these are the two cases that I wanted to.
Thank you, Siris. It was a very elaborate discussion and almost covered all the common pathologies. So
Yes.
The questions from the audience.
So we expect a lot of questions. Please, this is very much common in day-to-day practice. Both cervical radiculopathy and technique is very much common. So let's start. The main discussion is the main thing in this case scenario. Okay.
So just anticonvulsant treatment, is that enough for the first case? Should we add anything else like SNRI adjuvants, or because the discs are also involved there?
If it is a chronic one, then you should add, means if it is more than, this is basic thing for any of the kind of pain. So if it is a more than 3 months, then you can start an antidepressant as well. If it is a recent one, then the role is questionable.
Thank you, sir.
So, how long can the cervical epidural steroid injection last?
How long?
How long can the cervical epidural steroid injection last? The pain-free period.
It's again, the earlier we used to give the particular steroid. Even nowadays, in majority cases, I use the particular steroid. Particular steroid is longer duration of action, and the soluble steroid is having the lesser duration of action. But what is important that once you are breaking the pain cycle, somebody is having the pain for the longer time, you're breaking the pain cycle and starting the exercise program, then the action might be lasting longer. If you're talking about the soluble steroid, duration of action is only 6 hours. But what is important there, that if you are breaking the pain cycle, the duration might be lasting longer. I give this example to everybody, that if you have read the Bonica's first textbook, Management of Pain, I give this example almost always. What he have written in the preface of the book, that he was the army officer in army hospital. He was an anesthesiologist, and there during the Second World War, a lot of patient people used to come with different kind of pain, and many of them are chronic pain. And that time, that was the 40s. So that time he was doing only the local anesthetic nerve block with the short acting local anesthetic. So theoretically, the pain relief should last only for hour or two. But to his surprise, what he has mentioned very clearly, that to my surprise, the pain relief was lasting much longer than the local anesthetic block, and thus he was more interested in doing these patients, and gradually he gathered a lot of experiences. So this is true for many cases of the chronic pain, that if you are doing a just simple local anesthetic block or sometimes steroid block, then the pain relief might be much longer than the duration of action. And the most important explanation for this is you are breaking the pain cycle and you might be getting a long-term relief. Same thing is applicable for not for the cervical epidural, it is for the lumbar epidural. Some of the recent studies are there where the comparisons are soluble steroid versus solid deposteroid versus just local anesthetic, and it is telling that the results and the duration of actions might be similar. So now why the action is similar? Because local anesthetic action lasts only for 1 or 2 hours, the soluble steroid 6 hours, 6 to 8 hours, and deposteroids action is 3 to 6 weeks. So why the patient is having even with the local anesthetic, having a long lasting pain relief? Answer is the breaking the pain cycle might be doing the miracles. So this is not just true for cervical epidural, some other areas as well, that in many situations that the pain relief might be lasting much longer than its pharmacological duration of action. Okay. And for the soluble steroid, there is an upper limit. For the the deposteroid, there is an upper limit. For the soluble steroid, you can repeat it when pain is coming back. But definitely it is a risky procedure. It should not be repeated too often. And once the pain relief is there, patient should be going to the rehabilitation program, exercise program. And most important thing is your prevention.
Sir, I had a question.
Yes.
In the second case, sir, the patient is having headache on and off, like it is not every day. So in such patients for headache, what should be advised? What medicines should be prescribed, sir?
So sarcopenic headache is like that only. The sarcopenic headache, the pain might be not continuous pain, but it can be coming off and on. So sarcopenic headache, basically technique headache means it is exactly same as the sarcopenic headache. Means the pain is originating from the cervical spine and radiating towards the headache. So the treatment of these kind of things are almost similar. So here, if the pain is chronic, more than 3 months, you should be using the antidepressant like duloxetine. Otherwise, if it is a short term, then use the muscle relaxant and the analgesics and rehab program. And if still it is not, then you have to search the pain generator. It might be facet, it might be myofascial pain, it might be occipital neuralgia. So you have to target those things depending on the diagnostic block effect. Okay. So initial part, if the pain is short lasting, then analgesic, muscle relaxant and exercise program. If the pain is longer time, then add the duloxetine. If the patient is having no relief with this kind of medications, then you should be targeting, finding out where is the pain generator, and what series has nicely mentioned there, the muscles and the facets. They are the two common areas But apart from that, the other structures are there. Based on the diagnostic block results, you have to plan for the long-term management. And the same principle is applicable for the cervicogenic headache as well. Cervicogenic headache also same way. We have to find out the pathology, pain generator, and we have to target that pain generator.
Okay, sir. Sir, any role of topiramate, like anticonvulsants like this?
Yes, anticonvulsant is there definitely. So cervicogenic headache, the anticonvulsant. So you can use the pregabalin gabapentin. As a pain physician, you are much more accustomed with those things. But you can use the other anticonvulsant, like you can use the topiramate, you can use the divalproex. Divalproex, so I use very frequently the cervicogenic headache. I frequently use the divalproex, and patient is having the good relief with that. So this kind of anticonvulsants can be used in the initial period.
So these are all prophylactic or therapeutic we are giving?
Prophylaxis is the patient has to be correction of the posture, frequent break, 15-20 minutes break. After 15-20 minutes, maximum half an hour, you have to take a little break and don't look at your computer and these things continuously. So they are the very preventive actions. So this has to be emphasized rather than the long-term medications.
Okay, sir.
Myofascial pain syndrome, sir, how should we go about, sir? Like,
myofascial pain, you have to diagnose it. You have to stretch the muscle. This is the principle of any myofascial pain. Suppose this side has the trapezius myofascial pain. So what do you have to do? You stretch it to the opposite side, to the diagonal to the opposite side, and see whether the patient's pain is aggravated or not. Stretching, myofascial pain, stretching will be aggravating the pain. So, and you have also be able to find out the trigger zone. So if you are getting the trigger zone and stretching is causing the pain, then your treatment is your initially muscle laxant and analgesics, and later on, if the pain is recurrent or patient is non-responsive, go for the trigger point injection. Earlier, we used to go for the classical trigger point injections like a fan separated in the different directions. Nowadays, what we do, we give the dextrose injections just below that muscle. Suppose if you are thinking that the trapezius is the culprit, then you give the dextrose injection below the trapezius muscle. That gives a better result and long-lasting result rather than the just trigger point injection. So you give trigger point injection within the muscle also, and in the layer, in the facial plane with the next layer. If it trapezius, so below the trapezius, you give the 5% dextrose injection. What is the benefit of that? That means the nerves which are going into the muscle plane, that will be relaxed, because myofascial pain, one of the effect is on the entrapment of the nerves which are going in that muscle plane. So because there is a sustained contraction of that muscle in the myofascial pain, so the nearby nerves which are going in that plane might be getting entrapped. So along with the trigger point injection, if you are giving the dextrose injection in that plane, you might be getting a long-term benefit.
Say any volumes, how much should we give?
Trigger point injection, part trigger point, normally we give local anesthetic, but it can be dry needling, it can be steroid is nowadays.
5% dextrose, how much should we give, sir, the volume?
I'm coming to that point. First, I'm talking about the local anesthetic injection. Local anesthetic injection, it should not be mixed with steroid. Earlier, steroid used for this trigger point injection. Nowadays, we don't use steroid because steroid causes the muscle fibrosis and the contractility of the muscle will be reduced. So that is no longer used nowadays. And 5% dextrose, so normally the 5% dextrose injection is given something around your 5 to 10 cc at particular area. But if you are using 20 cc also, there is no harm, because 5% dextrose is, can be quickly absorbed, and it is a physiological solution. So it is not going to do any harm or anything. So, and it is very good in any of this nerve entrapment associated with the myofascial pain. Even if you are unable to identify any nerve entrapment, even then also, along with the trigger point injection, you can add the 5% dextrose, which will be adding the benefits.
Okay, sir. Many orthopedicians I've seen, they are writing L-carnitine, sir. I just wanted to ask, what is its role? And
there are so many people, people use so many, long list. One day I have to make a list about what are the all different, medications. which are not being,
The
empathetic.
L-carnitine, sir, the orthopedician, my orthopedician, he gives the
Why
injection also, sir.
L-carnitine? I'll be giving you the long list how orthopedicians and other physicians are using. So let us not discuss it.
Sir, how should we what care should we take in diabetics when we are giving 5D, sir?
That is not 5D. What is the 5% dextrose? How much is the total volume of the dextrose? It do not affect in any way. Sugar is increased much more with a steroid injection. There is a spike injections. But dextrose, 5% dextrose injection, 10, 20 ml volume do nothing. Okay?
So for dry needling, for myofascial syndrome, is there any specific number of sittings we should advise patient?
Dry, I told you one earlier what was used, that till the pain is going, there is still definitive sittings is not mentioned there. So sometimes 2, 3, 4, 5. But nowadays what I told you, same thing applicable for the local anesthetic in the trigger point injections. But nowadays the adding 5% dextrose below that particular muscle gives a long-term benefits. And to my experience, if we are adding this 5% dextrose, majority of the times only one session is enough. So what I told you that there are lots of recent papers are there. Myofascial pain is not just muscle is not the only culprit. That is the primary culprit. But secondary problem is your entrapment of the nearby nerves, which is going in the next muscle layer. So it goes on vicious cycle. The muscle contractions, nerve entrapment again causing the further muscle because by reflex, and then again it goes like a cycle. So unless you are breaking the cycle, these things will be going on. So there is no end of how many sessions you have to give this dye needling or these things. So best is if you are adding some dextrose injection in the muscle layer, the next layer, then the number of sessions will be reduced. As I told you, with my experience, majority of the times when you are adding the dextrose, normally one session is enough. Very rarely second sessions.
Okay.
But how many sessions? It depends on how much is the patient's response.
Okay, sir.
So anywhere in the body entrapment, we should give 5% dextrose, sir.
Nerve entrapment, nowadays the drug of choice is 5% dextrose, like carpal tunnel syndrome. Carpal tunnel syndrome is the commonest nerve entrapment syndrome. And if we are going for the recent literature, several meta-analyses are there, which is telling that it is much better than surgery. It is much better than the steroid injection. 5% dextrose hydrodissection of the nerve, median nerve entrapment is one of the treatment of choice nowadays. And the similar kind of things are there almost everywhere. Anywhere the nerve is getting entrapped, the drug of choice is your 5% dextrose around the nerve under ultrasound guidance.
Sir, one question.
Yes, we are waiting for your questions.
Sir, overall, when a patient is coming with neck pain, sir, how to grossly differentiate whether it is radiculopathy or myofascial or nerve entrapment or migraine or cervicogenic?
Already Sirius has discussed it.
Yes, sir. Yes, sir. He has discussed, but I just got confused with so many.
So many things from the first is from the history. From the history,
Yes,
the patient is having the radiation pain, depending on the which nerve root you are thinking. So first of all, you have to know the dermatome, the myotome, which muscles are from for which nerve root, and according to that, you have to see whether the pain is dermatomal or not, and patient's pain is having the neuropathic component or not. So if it is a radiculopathy or if it is a nerve entrapment like occipital nerve entrapment, occipital neuralgia, so there will be some neuropathic pain symptoms. If it is not, if it is a purely nociceptive pain, and if you are getting the local tenderness, then the possibilities of the facet joints and the myofascial pain. For the myofascial pain, stretching of the muscle will be aggravating the pain. For the facet joint, loading the facet joint will be aggravating the pain. So these are the few common things: facet, myofascial, and the radicular. So you have to differentiate in that way. But again, there are a lot of clinical tests what series has shown. So you please go through this video again and try to understand what are the different kind of tests done to differentiate between these three.
so we have to perform all these tests in every patient's coming with neck pain.
You should. But again, suppose somebody is having the the radicular pain. Then what test should we do? We should do the Sparling test, we should do the Jackson compression test, we should do the relief sign, we should do the destruction test. So depending on what is your initial history and initial part of the physical examinations you are doing, based on that, you have to decide what kind of special clinical test you should do. And depending on that, you have to finally come to a clinical diagnosis. And once the clinical diagnosis is made, then you should have an image. You have to match with the clinical diagnosis and image. And still, if the confusion is not cleared, then the last step is you're going for the diagnostic test. So this is the basic things for almost all everywhere, not just the neck pain. This is true for the back pain. This is true for the shoulder pain. This is true for almost everywhere. So series has very nicely discussed about the algorithms, about how to go ahead with that. And you have to remember the steps of the clinical examinations as well. Inspection, palpation, the range of movement, neurological examinations, and special clinical tests. So you have to perform all the clinical tests for all the areas, whether the patient is having the neck pain or shoulder pain or back pain or the knee pain. The basic steps are similar. And you have to, how do we normally see in our hospital? So a new patient, normally it takes approximately half an hour to complete the clinical examinations. If you are giving less than that time, you might be missing something. So you have to take the elaborate history, you have to take all the steps of the examinations. You must not be doing the jumping it. Once you are very senior, then you might be thinking, okay, you might be seeing the patients, you might be having some ideas. But still then, any step if you are jumping, you might be doing some mistake. And also there are several scoring systems like depression scoring system. There are the PHQ-9, there are fibromyalgia scoring system. So all those things should be meticulously followed. The chronic pain patient examinations, you cannot do it in a very few diagnoses are there where the spot diagnosis can be possible. But majority of the times, you have to take an elaborate history to come to a diagnosis. There is no shortcut.
Yes, sir.
Sir, I want to know how the Sperling's test is. Little bit confusion in that Sperling's test.
Sparling test is, suppose the patient is affected on this side. So you just gently, the bend the neck on that affected side. What is the purpose of doing it? That if we are doing it, the foramen of this side will be getting narrowed, so that if the root is involved, if there is the nerve root irritation or compression or the inflammation, so that in very gentle pressure and bending on this side. And then the foramen will be narrowed, nerve root will be compressed, and the patient's symptoms, radiating pain will be aggravated. But remember, it can be also positive in the facet joint, because facet joint in the cervical area can be loaded. Like, in the lumbar area, how the facet joint is loaded? By the extension. Extension is the most important movement for the lumbar facet joint and thoracic facet joint. And along with that, lateral bending and the rotation. But in the cervical, remember, the extension has very little contribution. The more important is the lateral bending and rotation. These two components are much more to load the cervical facet joint. Extension has very mild contribution for the cervical joint. So that means you have to remember these things. Okay, coming back to the Sparling test. So Sparling test can be positive for the facet joint as well, because when you are doing like this, the lateral bending, so facet joint also can be positive. So Sparling test is not specific for the radicular pain. It can be also the positive there in the facet joint. And another is your Jackson compression test, where you're rotating and then you are compressing. So that is called Jackson compression test. That is more for the facet joint. What I told just now, rotation and your lateral bending, these are for the cervical facet joint. Extension is not. So these rotations and compression, that is going to produce, that is Jackson compression test. That is more for the facet joint, but that can also be positive for the radicular pain. Another few tests. One is your destruction test. You just hold the one hand in the cervical, the protuberance, and one is there, and you just retract it, lift it for 30 seconds or more. Then what will happen? If the radicular pain is there, the radicular pain will be relieved because the foramen is opening up. But if it is a facet joint pain, that will be aggravated, because when you are distracting, the ligaments and other structures are basically getting stressed, and that can be, particularly the inflammatory facet joint arthritis, pain will be increased. And another is a relief sign. So if you are doing this, what is happening? Your nerve root is getting relaxed. When you are hanging the hand, the nerve root is getting stressed. So if you are doing like this, the patient will be telling my pain is relieved. So there are the few tests for the radiculopathy or radicular pain. And remember, none is conclusive. Only one test, it might be positive or negative, that cannot prove anything. So it has to be a composite clinical examinations, or the history, the neurological examination, special clinical test, all together you have to come to a conclusion. Even then, you have to confirm it by the MRI, and still if you are having the confusion, you have to use the diagnostic block.
Okay, sir. Thank you.
Sir, I want to ask.
So for
Yes, yes.
cervical radiculopathy pain, how long you wait for medication to act before considering cervical epidurals?
So this is true for the lumbar and cervical. This is almost similar. You give because if the patient is having the annoying pain, disturbing pain, and it is not working with all different kinds of medications you have given, so then you should be considering as a yellow flag or red flag. And in this situation, early interventions are indicated. So normally, what is the again, I'm telling you, this is not true only for the cervical. This is also true for the lumbar and the other kind of pain. Normally, within the 1 month, means 4 weeks, the interventions or surgery should not be done. It is I tell, this is the body's own time for healing. Body will be trying to take care of itself. It is body's chance, not your chance. So you should be treating it conservatively with your medications of the different kinds of medication depending on your diagnosis. But suppose the patient is having too much of pain, sleep is disturbed, daily life is disturbed. So should you wait for the 1 month? Saying that, okay, no, body's chance is 1 month, I'll not do anything. Answer is no. So exactly when should you do the epidural? There is no strict guideline for that. So initial 1 month conservative treatment, it is written everywhere, 4 weeks to 6 weeks. But if the pain is not relieved, the conservative management, you can wait maximum for 1 week. After that, you can go ahead with the epidural. But again, the thing is, if the patient is having a red flag, then you should not be doing the interventions. Then it is surgery what should be done. So the patient pain should be waited for 1 month for the conservative management if there is no red flag. Red flag means at any time, red flag means surgery. If no red flag, pain is still there more than a month, you should go ahead, stay with the epidural. Less than 1 month, you first try with the conservative management with all the different medications. If more than a week and still the patient is having pain, go for the epidural. Clear? And this is same thing is applicable for your lumbar as well.
Sir, what if we do the dural puncture while epidural?
Dural puncture, if you are doing it, if you are not doing a dural puncture, if somebody is tell, okay, I have done, several hundred cervical epidural or lumbar epidural without a single dural puncture, you just consider he is telling lie. Damn liar. So everybody in there, if you are asking me, sir, how many cases dural puncture you have done? I'll be telling several cases. At least 8 to 10 dural puncture I have done in my life. So it will be there, If you are telling, okay, I never punctured the dura, then either telling lie or he has not done much cases. Maybe only 1 or 2 cases he has done. So either of that too. So dural puncture is nothing to be get afraid. Thing is, if your dural puncture is there, you just change these things. Suppose you are doing at the level of the C71 and you have done the dural puncture. So you go on 1 level above and you can do there. So nothing to worry about that. Post-dural puncture headache might be there in some patients, but that is also not very common. Only thing is that when you'll be giving at the next level, give injection very, very slowly. Will the drug will go into the interthecal space? Answer is no. Why? Because fluid always flows from the high pressure to the low pressure area. So epidural pressure is what? Negative. Whereas interthecal pressure is always positive. So there will be flow of CSF from interthecal space to the epidural space. If you are giving very slowly, if you are giving very high pressure, then your pressure might be increasing and it might be going inside theoretically. But if you are giving the epidural injection very slowly, then your epidural injection will never go interthecally if you are giving it slowly. So there is no need of doing, abandoning the procedure. You can still go ahead with your the procedure. You just change the level, don't do the procedure at the same level, and nothing to worry. In some patients, there might be post-dural puncture headache, but in majority, it is not. Okay?
Thank you, sir. Thank you so much.
Sir, good evening. Sir, for cervical epidural intrathecal injections, if accidentally we do, sir, so it means, is it possible that even if we inject dye and confirm it in fluoroscopy, then also it is the possibility is there that we'll go intrathecal, sir?
Yes, you have to, why you are giving dye? To understand that it is not intrathecal. So you have to understand the difference between the intrathecal dye distribution and the epidural dye distribution. The clearest sign of the epidural dye distribution is you will be able to visualize the nerve root and the dye is coming outside the foramen, outside the spine lateral border. That is the surest sign. Apart from that, few other characters are there, like it will be a heterogeneous spread and the predictable volumes. That means in the cervical area, if you are giving 4 cc, it should be spreading approximately above 2 cc, below 2 cc, above 2 level, below 2 level. So these are the few characteristics of the epidural dye spread. But again, the intrathecal spread hot, it will be more homogeneous lateral than heterogeneous. The nerve dye will never come out of the spine lateral border. Nerve root will not be visualized. So if it is so, and another is your subdural. Subdural is which place? It is the space between the dura and the arachnoid. Accidentally, you might be going there. Intentionally, if I'm asking, okay, Bindu, give a subdural injection, it is very difficult because dura and the arachnoid is very closely packed, very thin layer, so it is difficult. But accidental subdural injection is possible. In my practicing life, I have done 2-3 cases of the subdural injection, lumbar also and cervical also. So subdural dye, how it will be there, how it will be knowing? Subdural space is a very thin space. So very small volume of drug, maybe 1 cc or half cc, it will be spreading wide area, 7-8 area, and it will be more or less linear spread. So by this way, you have to identify. So all these possibilities are there. It can be epidural spread, it can be subdural space, it can be your intrathecal dye spread. So you have to understand it, and you should be giving steroid only when you are in the epidural space. What will happen if you are giving intrathecal and if you are giving the drug? So the most dangerous complication is your arachnoiditis. Chemical arachnoiditis might be there, chemical inflammation, and it might be very dangerous. And second thing is if you are mixing with the local anesthetic, then apnea, that might be there, and you need to do the ventilation. So in one of my case, I still remember I came up with the intrathecal injection. Fortunately, that was a local anesthetic only. I have not given only local anesthetic what I have given there, and with the ventilation and the patients recovered. So the thing is, that time we used to do the blind cervical epidural technique. I am talking about in my early days. So I was in my anesthesia practice, I always used to go for the cervical epidural. I was very fond of giving it. So, but nowadays, if you are particularly giving the steroid injections, then you have to always confirm it with the fluoroscope. Without fluoroscopic confirmation, you must not give any epidural steroid injections. So coming back on to your question, that intrathecal, you have to identify with the dye. And if your dye distribution, you are sure about it, then only you should go. So, in my anesthesia practice, I can remember, we used to see the temperature on your back of the hand, see whether it is a hot or cold or warm. If it is a warm, then it is a CSF. If it is cold, then it is your drug. So those methods are very obsolete, and you should not be relying on that method. What is the temperature of the fluid, what is coming, whether it is a local anesthetic, what is you have injected is coming, or whether it is CSF it is coming. That is not the way to make the differentiation. Differentiation or confirmation should always be done with a dye injection.
Thank you, sir.
The volume of the drug to be used, sir, volume and dosage of the drug.
In the cervical epidural, you should be remembering this calculation for the lumbar epidural as well. So in the cervical epidural, if you remember per segment, how much volume is needed?
1.5.
No, I'm talking about the cervical. Cervical is 1 ml per level. That means if you are giving, just now I told, if you are giving 4 ml, 2 segment above and 2 segment below, because epidural, it will be spreading equally above and below. So that means suppose, and your needle entry point should be always C71. Why C71? Because that is the most prominent spine, and there is the kyphosis at that area, so that the interlaminar space is much wider compared to that other area. But the epidural space at that area is very less. To increase the epidural space in that area, you have to make the flexion of the neck. If you're doing flexion of the neck, upper thoracic will be drawing up. Upper thoracic epidural space is much larger. It is 3 to 4 millimeter. And the lower cervical, it is 1 to 2 millimeter. So if you are flexing the neck, what will happen? The cord will be drawn up. Cord is actually bulbous at the level of the lower cervical. Why bulbous? Because all the motor neurons for the hand is going there. So it is to accommodate all those motor neurons. The cervical cord, spinal cord at the lower cervical area is very bulbous. But at the thoracic, less motor neuron, so that the cord is compact and the epidural space is larger at the upper thoracic areas. So if you are making the flexion, then what will happen? The spinal cord will be drawn up and the upper thoracic epidural space will now come into the lower cervical C71 level. So now, when you are giving epidural at the always C71, now suppose your pathology is remain muted. So if you are giving, your target is 2 segment above, then how much volume should be given? 4 ml. Why? Because half will be going up, half will be going down. So each segment 1 ml. So if your pathology, suppose your needle entry point is C71 and pathology is 2 segment above, then you should give 4 ml. If it is 3 segment above, then 6 ml. If it is 4 segment above, it should be 8 ml. So in that way, you have to calculate. In the cervical area, never inject more than 10 cc. 10 cc is the maximum volume. Try to restrict yourself between 6 to 8 cc. But don't go up to 10 cc always. But actual calculation should be done in that way. For the lumbar area, this instead of 2, you multiply it with 4. Why? Because lumbar area per segment 1.5 to 2 ml is the per segment needed. So 4 ml. Why 4? It will be double. Why double? Because half of them will be going on the opposite side. Means if you are putting the needle there, half will be going towards your pathology side, half will be going to the other side where there is no pathology. That means the half will be wasted. That is the reason why you have to make a double. Clear? How much volume to be given?
Lumbar, sir.
4.
I didn't
Lumbar
understand.
multiplied by 4. Needle, your needle area and your target area. Calculate how much segment away and multiply by 4 for the lumbar area and multiply by 2 in the cervical area.
Okay, sir.
So, should we think of giving blood packs, sir, in case of PDPH in cervical area, like we can do in lumbar? Is it suggested?
I couldn't understand. Your voice was, there is noise in the background. Can you repeat it?
Sir, is blood patch advised, sir, for PDPH in cervical post?
It is already. Are you an anesthesiologist?
Yes, sir.
So you must be knowing better how to take care of the, the post-dural puncture headache. Blood patch is one of them, obviously, but there are many other ways.
We have never given in
Paracetamol,
cervical,
adequate
so I just
hydration.
wanted
Even
to
the
know.
stenoparatine block has been, recommended for the post-dural puncture headache. But blood patch is one of them. Okay, so let us end today's session here. Thank you very much, series. Very elaborate and detailed discussions. I'll be asking all the participants to go through those videos, and the clinical examinations history, everything has been covered by series nicely. So thank you very much, and let us go for wait for the next session. Next session I'll not be there. I'll be on my way traveling, and series and Milton will be taking care of that session next Thursday. After that, again I'll be there. So thank you very much and good night.